Okay, we are live. We can begin.
Good evening, namaskar to all. I hope everyone is fine and doing well. I, Dr. Dushyant Lal, on behalf of Abbott Primary Care General Medicine Division, welcome you all for this live interactive webinar on a very pertinent subject, very heated subject nowadays, that is COVID-19. We would be discussing today the management, home care management of mild to moderate COVID-19. We at Abbott believe that continuous medical education and knowledge sharing would definitely going to improve the patient outcome. And to continuing our efforts to achieve that, we have planned this webinar on a very lively and very in topic, that is COVID-19. We have planned multiple such kind of similar webinars in past also, and to continue our speed toward achieving the better patient outcome. Today we are having group of esteemed faculty with us who will be sharing their experience, their insights on different aspects of home care management of mild to moderate COVID-19. At the outset, I would like to sincerely thanks Dr. Zarir Udwadia for guiding us and for supporting us in conceptualizing this particular webinar today. And also, I would sincerely thanks each and every faculty member who has been enthusiastically agreed upon to be a speaker for this particular webinar today. So since January 2020, when this first case evolved in India, we have been navigating through this pandemic now for last 10 months. And in these times, we have experienced multiple kind of presentation of COVID-19, a clinical spectrum of COVID-19, and still we could not able to control it or overcome the COVID-19 currently. Since last 1 month, there has been an increase in number of cases in leaps and bounds. Currently, we have almost close to 8 lakh cases of COVID-19, and the mortality is already crossed over 1 lakh. So, as you all know, that most of these cases, almost 80% of cases, are from mild to moderate category, and these cases could be managed at home care settings with remote monitoring from the treating physician. We know that this particular pandemic has caused a lot of significant impact on the healthcare infrastructure and created a huge burden on our healthcare warriors, doctors, and paramedical staff. So, to throw more light on this, I would now welcome our moderator and speaker for the day, Dr. Zarir Udwadia. He is a consultant pulmonologist at Hinduja Hospital, Beach Candy Hospital, and Parsi General Hospital. He combines an extremely busy clinical workload with quality research, which is evident from his more than 170 PubMed Index publications. Sir is best known for his drug-resistant tuberculosis work. He has a special interest in these cases, but since the pandemic has come into picture, he has been immersed himself in COVID-19 related work and research. Sir has been in the task force from the government side to help informing the Mumbai's response or the Maharashtra response to government of India. I would also sincerely hope that today, after this webinar, we all would be having certain fruitful learnings and we could able to manage the patients at home better. I would also urge each one of you to ask as many questions as you have regarding the topics that are going to be discussed today. So we have now going to start this live interactive webinar on paradigm shift in COVID-19 care, a comprehensive home care management. And we would be having talk from Dr. Atul Mashru on role of general physician in home COVID care, followed up by Dr. Roshni on role of nutrition in home treated COVID patients. Then Dr. Amita Nene would be talking on nuts and bolts of home care of COVID patients. Then followed up by Dr. Zarir Udwadia talk on triage and medical therapy at home. And finally, the last talk would be by Dr. Ravindra Mehta on can oxygen be safely given at home to the hypoxic patient. This would be followed up by question and answer session. So I again request each one of you to ask your pertinent questions with the panelists. With this, without a further ado, I would now welcome Dr. Zarir Udwadia again and request him to take the proceedings ahead. Over to you, sir.
Thanks, Dr. Lal. Hope you can hear me.
Yes, sir.
and a warm welcome to my co-panelists and all of you in the virtual audience. I believe we have more than 1,300 registrations, which must be a record of sorts. I think this is a reflection really on the interest in this topic, a paradigm shift in COVID care towards comprehensive home treatment. And on a day when the global COVID count touched 40 million this morning when I checked last, you will agree that this is a worthy topic for discussion. So, my panelists and I hope to convince you that comprehensive care is not only possible, but that it is practical, it is feasible, it is safe for the majority of COVID patients. We'll start with the pivotal role of the GP, who's always the first responder to two extremely important and practical topics on the role of nutrition and a sound diet in patients with COVID who are at home. We will talk about triage and drug treatment. And finally, and I think most interestingly, Ravi will see if we can stretch the envelope and consider even home oxygen in people who are ill, but maybe not desperately ill enough to be rushed to hospital. So I think we should start by introducing the first speaker, Dr. Mashru. Dr. Mashru is a family physician who I've known for many years. His patients flock to him because of his wisdom and his 30 years experience in the field. And I always maintain it's easy to find 10 specialists of different kinds, but hard to find a good family practitioner. And since the pandemic has begun, Dr. Mashru has rolled up his sleeves like all of us and immersed himself with the care of all his multiple patients. And his topic is the unique perspective of the first provider, the family physician, who more and more patients will be calling upon first line. So, Dr. Mashru, could I request you to commence your talk? You have 20 minutes.
Yes, good evening, everybody.
You can share your screen.
Yes, good evening, everybody. I thank Dr. Zari Udwadia and Abbott for inviting me to talk about role of family physician in comprehensive home care of COVID patients. Now, my first encounter with COVID-19 patient, I would like to begin the unforgettable day in mid-March when a patient walked into my clinic. At this point of time, COVID was rampant in China, Italy, and other parts of Europe, but not much in India. He had fever, cough. There was no travel history. So I examined and ausculted it and spoke with him for almost 20 minutes. And I asked for an x ray and some blood tests, which was done at my clinic. X ray showed a patch of pneumonia, and I thought it was a community acquired pneumonia because of his comorbidities like diabetes, hypertension, and obesity. I admitted him at a tertiary care hospital. Within 2 hours of admission, this gentleman suffered a cardiac arrest and was resuscitated by two doctors. He was intubated and shifted to ICU. Next day, the news broke. He had tested positive for the dreaded COVID-19 virus. Patient passed away in couple of days. He was my first COVID patient and the hospital's first case as well. Because of this, I was home quarantined, tested twice, both times negative. I was saved. I think mask work. We realized this very early. As the pandemic took over the world and invaded our city, I saw cases mounting at a lightning speed and hit us with a thundering bolt. This novel and deadly coronavirus had caught us all unaware and totally unprepared. As soon as we got to know about this patient COVID-19, we looked into our CCTV, traced all the patients who were present in our clinic at the same time when this patient had moved around. With the help of CCTV, we followed his movements in our clinic and called each and every patient who seemed slightly closer. We asked few clinic staff personnel, security guard, and everyone else to quarantine themselves and notify if they felt unwell. Luckily, none of the 70 people we contacted had any problems. This incident had a deep impact on my practice. April and May, the terror and chaos of COVID spread across Mumbai, and we were struggling as family physicians with zero experience and no knowledge about this novel virus. Whenever my patient tested positive, they initially insisted to get hospitalized and we helped them with their admissions. Amidst the endless webinars, articles, and speculations about the diagnosis, treatment, and management of this disease, we slowly, very slowly, inched towards some understanding in managing these patients. As the month of June unfolded, hospitals were getting full, quarantine centers were getting full. Most of the patients complaining of cough, cold, fever after test were stamped as positive. Ironically, they felt extremely negative. Our patients didn't want to be whisked away to hospitals or isolation centers and didn't want to be treated by new doctors. They all wanted me to treat them and all wanted to be at home. The realization and value of home quarantine dawned upon us. Not all patients needed to be hospitalized, and not all were terribly sick. As the trusted family physician of years, I had to rise up to this challenge and thus came up with the idea of setting up a COVID home quarantine program, which was virtual but very real. We realized and understood another very important aspect during COVID times: telemedicine coming of age, is worldwide acceptance. We did the following things: used IT to the fullest, identified tools for group video consultations, linked our EMR infrastructure, set up means of communication with consultants, creating structured data sheets for tracking and comparative analysis of vitals and blood tests, shared sheets over internet that can be accessed by authenticated team members. We trained staff and set up SOP and installed necessary apps, created checklists for every team member. Firstly, we divided our work schedules into two OPDs. I didn't want to give up my conventional general practice at my clinic, where I actually see and examine a patient physically. So, my morning schedule was committed to the physical clinic OPD, where I see patients in a glass cabin with an adjacent glass cabin where patient walks in through a separate door and I examine through gloves and a stethoscope which have been fitted into glass wall. We installed a counter microphone system so we could hear each other very well. As a doctor, I want to practice with all possible precautions and not to be a super spreader. This way, I protect myself, my patients, and my family as well. The evening schedule was reserved for all COVID patients, and the IT driven virtual practice took over. We had made a team. The team includes a COVID expert, family physician. We are three of us. Nurses is there, lab technicians. There was an X-ray technician for home portable X-rays. Health managers are there. Dietitian on board. Physiotherapist is there. Diabetologist as and when required. IT personnel. We made a list of essential medical devices that includes pulse oximeter, thermometer, BP monitor, glucometer if diabetic, and incentive spirometry device. Now, for steps of processes, over to my colleague, Dr. Dipali Bhatt.
Dipali is muted. You need to start again, Dipali. You were muted. Yeah.
Yes, can you hear
Yes,
me
yes.
now? Yeah. All right. Good evening, everybody, and thank you, sir. I'll narrate all the steps of the process. Step one: once a patient is diagnosed with COVID 19, either by RT PCR, CT scans, he would call us with a request for home quarantine under our care and supervision. Step two: we would then assign our clinic center head, Dr. Rupa, for further communication. The patient was also explained the harsh reality of this 10-day program, that he or she may have to be hospitalized in case of any need as the days progressed, as per doctor's evaluation and advice. Step 3. Appoint a personal health manager to each and every home quarantined patient. This health personnel would take all their calls 24 by 7 and connect with us doctors in case of any urgent need. She was assigned to collect their vitals 3 times in a day. If they required a portable EKG, X ray, or an ambulance, she would do all the arrangements. She was their all time support for communications. She made sure that the devices were bought and used correctly by patients. Step 4. Make an elaborate history call. We did a 45-minute video call along with the patient and his family. History taking remains very important in this to have the most accurate timeline to find the first day of symptom, their habits like smoking, tobacco, their symptoms, comorbidities, and current medication, and so on. At this point, we also counsel the patients very well. This is extremely important and necessary as patients suffered from immense anxiety. Once we saw them and spoke to them, they felt much comfortable. We also taught them how to position themselves in front of the phone camera, the right position of phone camera so that we could see their face, neck, upper chest. This enabled us to evaluate them, their respiratory rates, and whether the accessory muscles were working, and so on. Step 5. After the history call, we doctors scrutinize the entire patient profile, and finally the decision to take him or her for the home quarantine was made. Step 6. After the formal enrollment of the patient, their assigned health manager would do some groundwork about the area that they lived in. Through this program, we could supervise patients all over Mumbai and India. Whether it was Delhi, Kolkata, Surat, Kolhapur, or Coimbatore, we could extend our services to all these patients. We connected and reached out to COVID experts in these cities as a backup. In case of admission, in case of need of admission, we also connected with the local labs, imaging centers for their X rays and CT scans, and the lab work. Step 7. We explained the home quarantine protocols to the patient and his family twice or thrice. Step 8. Our IT team emailed the X-ray film, CT scans, comparative lab work results to the patient, all the doctors involved, and the COVID expert on our panel. So, the consultants were provided with all the relevant data of the patient they were now all set to see. Step 9. The video conference call with the COVID expert had our team of doctors, the consultant, patient, his chosen family members. We presented each case with the full and detailed history, relevant past history, BMI, comorbidities, current medications, and the vitals like temperature, pulse, BP, oxygen at rest, and oxygen after the 6-minute walk test, and the breath holding time. Step 10. As soon as the call was over, the e prescription was generated and shared with the patient and his relative. The list of tests required to be done was also shared with them. We taught the patients how to inject themselves with insulin, low molecular weight heparin. It was quite overwhelming for them, but they all did it. How to take the inhalers if they required, till they understood and did everything correctly. Step 11. Daily virtual rounds. We did daily virtual rounds, collected vitals, compared the blood tests, evaluated patients and their new complaints. We did consultations with the COVID expert if there was a need. Monitoring and comparative analysis of vitals, complaints, and lab work, all this helped us to identify the trend of the infection during this 10-day program. This was very crucial and it was very scary in the beginning. But then we settled and operated quite seamlessly. Now, I would like to state some of the statistics of this group that we had done home quarantine for. You can all see the slide here, and I will just speak out some of the numbers. Total number of patients who were home quarantined with us were 226, out of which 148 were men, 78 women. The CT severity score was mild in 72 of them, moderate in 20, and normal in 7. Those who were treated with favipiravir were 102, oral steroids 92, low molecular weight heparin 93, the newer oral anticoagulants 87, antiplatelets 71. Total number of diabetics that we had were 39, hypertensives 48, dyslipidemias 88, a few asthma patients like 3, 8 smokers, 9 tobacco chewers. Those who had past history of COX were about 6, 1 ILD patient. Now the age group we classified 20 to 35, there were 43 patients. 36 to 55, 121 patients. 56 to 75 were 51, and 76 and above were 7. The BMIs 25 to 30 BMI, there were about 101 patients. 31 and more BMI, 37. Out of these 226 patients, hospital admissions were required for 20. And out of these 20, there was one very sad, unfortunate death. In our study, we did not find any correlation between blood groups and the severity of the disease. Over to Dr. Mashru again for the next slide, please.
Well, there was plenty at the start. Patients were always unsure whether they did right by opting for this. Network issues made the video calls hazy at times, making it difficult to see and evaluate a patient, and patients would be tired and sleepy. A tragedy occurred when we started this program in early June. We lost one patient. He was using a wrist oximeter of poor quality and used to share his vitals verbally. Faulty interpretation of such gadgets led to a bad outcome. He was a case of happy hypoxia, which was diagnosed at a later stage. We then insisted that patients clicked pictures of their readings and shared with us. Like all the doctors around the world, during this pandemic, our learning curve was steep with the help of our COVID experts. Every day we learned something and applied this newfound knowledge on our patients. Our practice evolved to a great extent. Most importantly, we could sense and identify the red flags. In spite of difficulties, video consultations work and in such cases have advantages too. EMR management is a must, and there is a need to formalize the process. Be proactive. Keep monitoring, especially during second week. Identify the need for hospitalization as early as possible. Stay adamantly scientific. Don't underestimate this virus. It is nasty, unpredictable, and may create a storm as the second week begins. Don't get carried away by kadas and ukalas. They cause acidity to Indians, and nothing probably happens to COVID 19. Don't get carried away by antibiotics, HCQS, anti-malarials, anti-helminths to break this virus. Reserve our time-tested medicines for the right disease. Imagine the drug resistance we will create by doing this. Don't do unnecessary tests like IL-6. Don't do CT scans in the early disease. To combat this virus, I used and benefited from the antiviral from Japan, that is favipiravir. Fever may last for 21 days, but high fever is a red flag. Post walk fall in oxygen by 3% needs close monitoring or admission. Don't celebrate till patient finishes third week. Anything can happen. Post COVID, we saw one ITP, there's a facial palsy, lung fibrosis, stroke, DVT. To predict the cytokine storm, use the COVID markers blood test at the right time. The rising trend of CRP, drop in lymphocytes count, rising D dimer, etc., act as a warning sign for the incoming storm. High fever, increasing cough, and post hoc fall in saturation are not good, may need admission. We arranged for ECG at home for those who complained of chest pain, cardiac enzymes, portable x-rays if cough not settling. All such tests help us to make a smart and fast decision. Our virtual rounds were not just vitals. We motivated patients to do breathing exercises and cheered them up with humor and infused them with a lot of positive thinking and persuaded them to quit smoking hookah and tobacco. Emotions at work. At times, I was forced to take up very old patients for this. In spite of our advice to get hospitalized, they chose to stay at home. They were 91, 89, 84 years old. Very patiently, we had to train them and teach them how to use smartphones. And surprisingly, they all did very well. I got up at erratic hours with nightmares of breathless patients gasping for air. Actually, I used to wake up at 3 or 4 a.m. and wait for the sunrise. I call them in the morning, early morning. And when I hear his voice, my 90% tension is over. Friends, as our chairperson, Dr. Udwadia, has rightly said in one of the webinars, after this earthquake of COVID, tsunami of lung fibrosis may follow. Brace yourself, it is not over yet. Since years as family physicians, we have always fought various infectious diseases and chronic conditions with our full capacity. In this pandemic, also, we wanted to do our share of duty as COVID warriors and play a meaningful and vital role, and we have achieved some by doing this home quarantine care program. Thank you.
Thank you. Just stop sharing your screen, Dr. Mashru, so I can see all again. So if I could reach out across the screen and shake both your hands, I would do that, because Atul and Dipali, that was an outstanding talk. I think everyone in this 1,300 plus audience will realize the importance and value of a good and caring family practitioner. As I said, it beats 100 consultants and specialists, according to me. You've learned on the fly about a new disease, like all of us, you follow. You have used technology and embraced it much better than I could, for example, for sure. In fact, family practitioners like you would put, I think, those in the West, anywhere in the West, to shame and to the shade. So my congratulations for a really outstanding presentation. So well done. And keep up the good work that you both do.
Thank you so much, sir.
Well done.
Thank you
Well
very
done. Thank you. Shall we move on now? So the next speaker, I can't see Roshni, but I think she must be on, is an American board-certified endocrinologist from Chicago. She moved from the US to India 10 years ago, I think it was, and took up consultants' jobs at the Hinduja and Breach Candy. And then, against the grain, she chose to leave hospital practice, setting up her own clinic called Asan, which I think, when I asked her a few days ago, means teacher. She is what I would call a truly holistic physician who would rather spend time treating the root cause of a problem than prescribing 100 drugs hastily and providing a quick fix in that way. She will address this crucial question of nutrition and answer every Indian patient's favorite question. So, doctor, what do I eat? So, Roshni, you have 20 minutes.
Thanks, Zarir, and thanks to Abbott for having me here. I was very inspired by the previous speakers, Dr. Mashru and Dr. Bhatt. I'm reassured that there are family physicians like you guys still around, and the primary care system still works. So thank you for that. I'll start. Let's see how to share. How do I share your entire screen?
Ma'am, click on the share.
Yeah, I'm clicking share screen.
And then click on your entire screen and click share.
Your entire screen. So the blue
Click on
button is not lighting up
yeah.
though. Share is not going blue.
So click on the small screen, the blue color will get highlighted.
On the
The
small
button
screen.
will
Oh
get
yes, now it's highlighted. Yeah, now
highlighted.
now you guys can
I
see
got
me.
your screen, ma'am. Just start your
Yes.
presentation.
Do you see my screen now?
Yes, ma'am. Just start your presentation.
Okay. All right. Thank you so much. Okay, so let's get started. So of course, I'm not a frontliner. As Dr. Udvadia said, I have moved to a completely outpatient practice, but my practice does involve people with diabetes, obesity, hypertension, and insulin resistance. So I've been looking at it from that angle, that we know a little bit about what prognosticates worse outcome, whether it's morbidity or mortality. My role today is to show the connection between nutrition and insulin resistance and maybe this inflammatory process. So some early data from Wuhan, this is from the month of May, which showed a marker called the TYG index, which you calculate by fasting triglycerides, multiply by fasting glucose, and you divide by 2. You don't need to get worried about the math. The higher the triglycerides and the glucose, the higher your index. And they found in this Wuhan group that the higher this number was, the patients were doing worse across 3 tertiles, whether they looked at morbidity or mortality. Patients were actually doing much worse as the tertiles went higher. So this was statistically significant. It, of course, doesn't point to causation. It was merely a correlation, but it was a strong correlation. When they adjusted for other inflammatory markers like CRP and TNF alpha, this connection went away. So we don't think it's TYG index by itself. There's obviously a lot happening besides insulin resistance alone. But maybe what ties it together is the inflammatory response. And my role here, the way I'm looking at this is, we don't yet know how to adjust CRP, TNF alpha, or the cytokine storm through nutrition, but we know a lot about how to manage triglycerides and glucose through nutrition. So that's going to be the focus of my talk. What do we know about triglycerides? Again, and I'm going to keep flashing the formula there so you remember why we're coming back to these markers. We know the cardiovascular risk profile that comes with high triglycerides. It's definitely not a healthy marker to have from a metabolic perspective. How do triglycerides affect cardiovascular health? These are the mechanisms we think are at play: endothelial dysfunction, inflammation through cytokines, and coagulation. And these happen to be the same things that look like they're happening in COVID. And all you frontline physicians will know that better than I do. But from the textbook connection, this seems to be a connection between triglycerides and maybe some of the inflammatory response in COVID as well. So, but triglycerides are easily modifiable with nutrition. So what's the first thing I need to show you? This is the only endocrine slide I need to show you. This kind of ties together inflammation, nutrition, and endocrinology. So up on the top, it's dietary sugar, which is fructose, dietary carbohydrates, which will raise your insulin levels naturally. Now insulin has a lipoprotective effect, so you can't burn fat. Your body has to start burning sugar when you are exposed to insulin. So it's a very paradoxical thing that happens, is that you take in sugar, you have high triglycerides now because you're not able to burn the fat, and you have high sugars as well when you get into a vicious cycle of insulin resistance. So this is not healthy. And the unfortunate side effects of this are the uric acid goes high, reactive oxygen species, fatty liver starts to happen at the level of the liver, and all of these markers tie to inflammation, insulin resistance. Now, I'm holding this slide for one more second because a lot of times when we see a high uric acid in India, the patient will be told to stop eating their pulses. And again, from a vegetarian protein perspective, pulses become an important thing. So if you want to affect uric acid, really what you need to be doing is reducing sugar and reducing carbohydrates. There's a direct link between fructose and uric acid. But for the point of corona and COVID today, the thing I wanted to talk about was the link with carbohydrates and triglycerides. Now, how can you affect the sugar levels, fasting sugar levels, as that was one of the correlations with bad COVID outcomes? What can you do from nutrition to affect glucose levels? That's an easy one. We know that from the world of diabetes. Okay, so again, this is the American Diabetes Association document. It comes out every January. It's a reliable manuscript to look at for what's new in diabetes care. This is a 2020 document. And I won't read this difficult piece of paper to you, but it's the medical nutrition therapy for diabetes. And in summary, what it says is going low carbohydrate or very low carbohydrate naturally brings your blood sugars down while reducing your diabetes medication. So this is an accepted way of treating diabetes. This is science. Okay, so going low carb helps you bring the blood sugars down. And when they talk about what carbohydrates, they use the word whole foods. Watch that word though, because I'm going to talk about whole foods versus whole grains and how we get a bit trapped up with that. Again, avoiding the added sugars and refined carbohydrates. It sounds obvious, and yet all of us struggle with reducing the sugar in our diet, don't we? So then how much carbohydrate? How low should my carbohydrate go? This is a 2019 document for people with diabetes or pre-diabetes, where the amount of carbohydrate you need is actually unknown. We don't know how much carbohydrate you need. There's actually no number because the body has plenty of mechanisms to create energy from breaking down glycogen, gluconeogenesis. If there's no more carbohydrate, it'll burn fat, burn protein, convert it into glucose, ketones if it's a very low carbohydrate intake. So there's really no essential carbohydrate. The way we know about essential fatty acids and essential amino acids, there's no essential sugar which needs to be consumed. Glucose is necessary at the cellular level, but the body has all the backups in place to make glucose within. So you don't need to be fed glucose to keep your energy levels up. What about processed food? And what about coronavirus? And what about insulin resistance? So this came out this month, October 2020, where they looked at the New York public health data on COVID, and they found that the processed food related non-communicable diseases, all the chronic diseases that are in my world, type 2 diabetes, obesity, hypertension, fatty liver, who have the common link of insulin resistance, those are directly correlating to worse outcomes in COVID. Now, I understand that, as Dr. Mashru said, there's a lot of other things you have to focus on when you're in a pandemic. This is not the time that you're going to go and solve the economic divide and social problems and world problems of chronic disease and all the inequalities that create this chronic issue. I need to focus on oxygen levels and keeping this person alive. So lifestyle change is not for now. Well, what if I told you that adding or taking away sugar from someone's diet can have a positive or a negative effect in as little as 9 to 21 days? Sugar can cause measurable harm in 21 days. This was a randomized controlled trial, diabetes care. This was the approximate amount of fructose given to a person. It's not a lot. There were no pastries or cakes or anything. It was stuff that you might even consider healthy: muesli, a juice, not even a soda beverage, one fruit, tablespoon of honey, about three biscuits, the equivalent of that amount of fructose. And in 21 days, this study, they were able to make healthy men unhealthy. The triglycerides went up in 21 days, and they developed insulin resistance on the gold standard tests. Okay, this was a very interesting trial, RCT, where they could cause harm by giving fructose in 21 days. More relevant for today's talk and for our patients who are experiencing COVID is stopping sugar has been shown to have a measurable benefit in 9 days. This was Dr. Robert Lustig, a pioneer in the battle against sugar. And this was a study he did where they did isocaloric fructose restriction. So they kept the carbohydrates the same. They just replaced sugar with starch. So this was not even a low carb study. They basically just took out sugar in the form of fructose from high-risk children, Latino, African American high-risk children. They took the sugar out, and in just 9 days, the triglycerides came down, OGTs improved, oral glucose tolerance tests improved, hyperinsulinemia improved, all statistically significant. Weight came down in just 9 days. In fact, one of the study requirements was to keep the children's weight constant, so that wouldn't falsely give the benefits on triglycerides and insulin. So they had to struggle to maintain these kids' weight for those 9 days because they rapidly started losing weight when they took away the sugar. So when we are dealing with a pandemic with no curve in sight and no cure in sight, 9 days is pretty short. And why wait for that PCR test to come positive and the call comes to the doctor? Should I start worrying now? How about before the cause for worry starts, 9 days starting today, why aren't we taking the sugar out, processed food out, and get this benefit into everybody's homes? So, what are the steps you can take? Where can you start working to get sugar and fructose out of your diet? Let's talk about that now in terms of practical things. If you want to remove sugar from your diet, you have to be very careful because the food industry knows and they have found multiple ways. I've put with the red arrow some of the traps in the Indian market. A lot of people feel that coconut sugar, dates, dried fruit, like dried anjeer, that's a sugar that's preferable in some way. Jaggery, honey, they think is okay. Fruit juices, they think are okay. Like, oh, this patient has an illness, let's give them juice to keep their energy up. You're giving them sugar. High fructose corn syrup, of course, you'll read on the package labels and you'll know. And again, jaggery, these are all sugar and they all have fructose in them. Now, you're obviously, all of you are physicians on this group. This is not going to fool you when you read a label of ketchup. It says made with 100% real tomatoes. I mean, I don't know what's a 60% real tomato, but it says 100% real tomato and it says fresh tomato on the pack. And, I think you know the difference between this and a fresh tomato. When you read the ingredients, it's now tomato paste and sugar, preservatives and stabilizers. And for every 15 grams of ketchup, there's 5 grams of sugar in ketchup. Okay. So it's important to read these labels when you're removing packaged food from your house. I have this objection from patients all the time, but mine is whole grain. I bought whole grain. So let's look at what whole grain labeling actually means. When you eat something which in Indian kitchen is considered light, and even our hospitals do this, they serve idli and poha and upma. Idli is from rice, but if you look at a whole grain of rice and you look at an idli, a lot of processing has happened to convert the grain. So it's no longer a whole grain or a whole food anymore. It used to be a whole grain. Upma, shira, and wheat flour, refined flour versus the whole kernel of wheat. People think makhanas are okay, those lotus seeds, but I had to go watch a YouTube video. The number of steps required to take a lotus seed and turn it into a ready-to-eat instant food. Ragi khakras and ragi biscuits, people think these are diet foods, that they are gluten-free. Yes, they're gluten-free, but they are not low carbohydrate. And again, look at the comparison with the whole ragi millet. So here's a way you could get confused with a box. This box has tried very hard to make you think you're making a healthy choice. They've written whole grain in 3 places on the front of the box. And I magnified this. Again, it says 100% of the grain is whole grain. I don't even know what this means. It's probably, if you're busy, you'll just say, it sounds like it's whole grain, let me just buy it, right? Who can even analyze this? And when you read the back, this is a ready-to-eat cereal, right? So it says brown rice flakes. Now it's not saying whole grain rice. I showed you the picture. They have a picture of whole grain rice on their box, but that's not what's inside the box. You have rice flakes, which you can pour milk or you can have it straight away without even chewing it. They have jawar flakes, and whole grain jawar looks very different. Ready to eat for somebody else, not you and me. Oats, again, whole grain oats are at the top. That's a whole oat. And a processed oat, all these other pictures are pictures of various ways you can process oat. But only the top one is the whole grain. So be careful when you're buying whole grain. It should look like a whole grain. Otherwise, it has been processed, and the way it affects your carbohydrates and insulin is going to be much faster. You're going to have a much faster insulin and glucose response to processed grain. So what can you do? You'll say, I don't buy packaged food. I don't buy box food. My patient has COVID. I'm going to feed them from my kitchen. What should I do from my house? All right, so let's talk about that. Throw out the processed food, packaged food, soda. You're not going to give your family soda when they're sick. Let's look at home food. Cut your carbohydrates to half. Whatever is the menu, if you are taking 4 chapatis per day, cut it to 2. Replace that space in their stomach if they're feeling hungry with more dal, more vegetable. It's the same menu. It's tur dal, it's bhindi, it's roti. Go half on the roti, go double on the protein, the dal and the sabji. This person probably will not be left hungry with this much food on their plate. What about fats? We want more healthy fats. Again, remembering from that insulin pathway I showed you, it's eating carbohydrates that raises fatty acids in the blood and raises triglycerides. Eating fats actually causes less of an insulin response. So by eating fat, you don't raise your blood fat. By eating carbohydrates, you increase your inflammatory blood fats. So the way to reduce that is to prefer less processed, most natural form of healthy fats. And I'm not going to read all these things out, but I'll make one comment is dry fruits. You know, people will say dry fruits. When I say dry fruits, I mean dried cranberries, dried dates, dried apricots, and dried raisins, okay, dried grapes. Those are fruits. Those have fructose. That's not in healthy fats. I'm talking about nuts. So in India, because you buy the nuts and dry fruits from the same shop, they think nuts are dry fruits. Please keep those two things separate. Dried fruits are rich in fructose, very high in fructose, and nuts are a healthy fat and source of protein. Again, we're trying to avoid all these processed fats. If the budget allows, again, we are talking to a pan-India audience today, so I'm sure there are people from all over the country. If the patient's budget allows at home, there are a little bit more expensive fats that can be added to the pantry, which would give more satiety and have less of an insulin response. Protein is a very big one. I have 3 minutes left. Most of the Indian kitchens have insufficient protein going into their diet. So when we say that go from insufficient to normal, we're just bringing them from about 0.3 on an average. When I talk to my patients, they're getting about 0.3 grams of protein per kg. Let's talk about a 60 kg person or a reference body weight of 60 kg. They need about 48 to 60 grams of protein a day. So I'm just asking them to come to normal. Why? Because you will be full, you will not require to go for carbohydrates to fill your stomach, and you will be more satisfied with less of an insulin response. So no, we're not asking you to go high protein, we are just asking you for normal. And actually, when you look at the target from the Western perspective, 0.8 is a low protein diet, not a high protein diet. So Indians get worried, oh, this is a high protein diet. It's higher than where you were, but I'm bringing you to normal. Please understand the maths going on here. These are some examples of plant-based proteins that you can add through the day. You will need to be working more consciously as a vegetarian to make sure you get enough plant-based protein at each meal. It's a little easier when you're okay with animal-based protein. This is one portion of a deck of cards. Like if you see a deck of 52 playing cards, palm-sized piece of boneless meat will give you about 25 grams of protein per serving. If someone says, but I'll get gassy, I'll get flatulence with pulses and beans, I can't tolerate it, it's too heavy, reassure them it's a new thing in your diet. Your gut bacteria has to get used to it. There are new carbohydrates, complex sugars in there, fiber. So the government is changing in your gut, and that tends to raise a stink. You know that when governments are going through change, it causes a lot of stink. So you need to pay attention to that and reassure your patients that adding protein is going to be okay. I'm just flashing this slide just so you can quickly scan through. The middle column is what things you can increase in your favorite Indian meals and your variety. I'm Gujarati, and Gujaratis love to eat for variety. So when you want variety foods, how can you quickly increase the nutrition of the meal without compromising on the enjoyable factor or the experience factor? Put the rice as a garnish on the top. You don't need the bowl to start with rice at the bottom. Fill it with your dal and your gravy, your coconut curry. Use rice as a garnish. In summary, we're trying to keep insulin, glucose, and triglycerides low to reduce the inflammatory response. This is based in science, okay? Reduce the snacking if they're overweight, for sure. And again, avoiding the processed food. So last parting thoughts is, if someone eats like this because they're health conscious, constantly grazing, they're basically creating an insulin response through the day. This is chronic hyperinsulinemia by someone who's health conscious trying to eat throughout the day. Let's merge those meals and snacks, combine it so that you have time in between meals without so much insulin exposure. That will bring your glucose and triglyceride levels down. And here again, you put the proteins through the day for satiety and fullness, add enough healthy fats through the day. This is just a suggestion how you can go. And I'll leave you with a poem, because I like to write poetry once in a while. Is, in a sweet tooth world where consumption is the norm, where sabji needs roti and an extra one if it's warm, where dal and sambar make sense with rice, where eating them alone cannot taste nice. Awaiting mask, vaccine, and drug to solve the infection. Insulin resistance and COVID, a mysterious connection. Let's go home this Sunday a little more wise, and low-carb menus in our homes revise. And with that, I am happy to conclude. Thank you very much.
Thank you very much, Roshni. That was such an important and practical talk. You're also a gifted poet, not just a great endocrinologist. And I think there are important lessons here for us when our patients ask us what we need to do in terms of their nutrition. I'm going to stop chocolates for 9 days and move over to lotus seeds. You'll be happy to know, though they sound terrible. Okay, so let's move on. And it's a pleasure to introduce the third speaker today, Dr. Amita Nene. Amita has been my colleague at the Hinduja Hospital many years ago. She then moved on to Greater Heights, where she's currently the head of the Bombay Hospital chest department. She's a great academic. She has over 50 publications. I think her greatest credit these days has been that she's conducted the first DNB respiratory exam in the midst of a pandemic at Bombay Hospital, despite being overwhelmed by her clinical and ICU duties. So Amita, really a bow in honor of that. And she'll bring her considerable powers of organization to the nuts and bolts of quarantine. And really this, if you're talking about home care, this is the heart of this symposium. So Amita, 20 minutes.
Thank you very, very much. First of all, I'd like to thank Dr. Udvadia for making me a part of this fantastic initiative, and hats off to Abbott for making sure that such a wonderful program is made available to everybody where it's going to be so useful. Is my screen being shared?
No, ma'am, not yet. I cannot see your screen yet.
Okay. You have to do your entire screen.
Just click the share screen button, select your entire screen and click share.
Okay. Right. I've shared now.
No, ma'am, I haven't received your screen yet.
Yeah, just a minute. Huh?
Yes, ma'am.
Wait.
Click the share screen harder. That needs to highlight a bit.
I think so. Yeah. Okay, fine.
Yeah. Press share
click
screen
on your
hard.
entire screen. Click on that entire screen, your entire screen.
I clicked on it, yeah.
The share button will get enabled, ma'am.
Yes. Now it's done.
Yes, ma'am, I got your screen now. Open your presentation and continue.
Okay. So basically, the thing is that a very interesting study came out in Lancet May 2020. And this study was basically saying that if we want to curtail the spread of COVID-19, then would home care be better or would institutional care be better? And no guesses. Institutional care was much better if we had to curtail the spread of COVID-19 outbreak. If this is so, then why are we actually having this webinar at all? Why are we talking about home care for COVID patients? So this is basically because a shocking headline came in Times of India a month back, and it said that now India has become the second country in the world after US to record 5 million COVID-19 cases, and the last 1 million were added in a record period of less than 11 days. So since the COVID numbers are persistently increasing, it is not possible to admit each and every COVID patient due to non-availability of the beds. Also, many patients are uncomfortable getting admitted in the hospital because they don't want to be away from
sharing just now. Need to expand it again?
Yeah.
Perfect.
Also, many patients are not comfortable getting admitted because they don't want to be away from their family or not be able to meet them. Also, very often patients have small children and therefore they cannot get admitted. Thus, providing good quality home care for selected COVID patients would be the best way forward. So when we want to suggest home care for COVID patients, the patients and the relatives will have just so many questions. So to make this thing easy, I've actually decided to give my talk in the form of question answers, the important questions that we'll be asked and therefore the answers that we should be giving to our patients. So the first question is, what factors should be considered for providing home care for treating COVID patients? So 3 factors play a very important role in providing home care to COVID patients. These are patient-related factors, caregiver-related factors, and home-related factors. So let's first talk about the patient-related factors. So most important question, who is an appropriate candidate for home care. So we need to understand that home-based treatment is not for everyone, and it requires case-by-case selection, and certain criteria have to be looked at. So certain baseline factors like risk factors, age of the patient, social factors, severity of disease, and local rules and laws of the state have to be looked into before we decide to suggest home care for a patient. So as per the ICMR guidelines, a patient who is asymptomatic or is mildly symptomatic is an ideal candidate for home care. So we know what an asymptomatic patient is, but what is a mildly symptomatic patient? So a patient who's got an uncomplicated upper respiratory tract infection and has only mild symptoms like fever, cough, sore throat, nasal congestion, malaise, headache, and if his saturation is normal, more than 95%, these are the only people who could be considered ideally for home care. Of course, if the doctor is experienced, and if we have, now that we are into COVID for more than 6 months, we all have become more brave, and of course, we can also provide care to certain patients who are moderately sick. And Dr. Udvadia and Dr. Ravindra Mehta will talk about this in their talk. We need to understand that patients who are immunocompromised, that means patients who are HIV positive, who are transplant recipients, who are on cancer therapy at present, are not eligible for home isolation. Also, elderly people more than 60 years of age and those with comorbidities like hypertension, diabetes, heart diseases, chronic lung, liver, kidney diseases, or cerebrovascular diseases should be allowed home isolation after proper evaluation by the treating medical officer. So that means while immunocompromised patients are not eligible for home care, those patients who have significant comorbidities could actually be managed at home if we look into certain important factors. The patient, most importantly, should agree to monitor his health and should regularly inform his health status to the treating doctor. The patient will have to fill an undertaking on self-isolation and shall follow home quarantine guidelines. The treating doctor should satisfy himself before allowing home isolation. So these are the patient factors which have to be attended to before we decide to offer home treatment to the COVID patient. Caregiver factors are very, very important. So a caregiver should be available to provide care on 24/7 basis in the house of the patient. What is really important is that we should limit the number of caregivers. Ideally, we should assign only one person who's in good health and has no underlying chronic or immunocompromising conditions as a caretaker. And this caretaker, of course, should be intelligent, reliable, and well informed. He should be taught about the close monitoring for any signs of symptoms of deterioration of the patient's health, and he should be able to detect these symptoms and should be able to inform us immediately. And a communication link between the caregiver and the treating doctor is a prerequisite for the entire duration of the home care. Home factors are also very important. The patient should have a well-ventilated separate room, and there should be an attached bathroom which will be used only by this patient. A trained healthcare should actually assess whether the home in question is suitable for isolation, and it is mandatory that the family members are intelligent and would be able to adhere to the required rules of hand and respiratory hygiene, waste management, restricted movement into the patient's room, etc. So if the patient's family members are not going to be very intelligent, and if we cannot expect them to follow these guidelines, then of course we cannot be advising home care for this patient. So after addressing each of these important factors, we have to, a very important question asked to us is, what is the checklist to be ensured before commencing home care? So this is very, very important because we have certain basic requirements. There should be a triple layer medical mask. Ideally, N95 masks should be available in plenty. Eye protection glasses or head shields also should be available. There should be gloves, sanitizers, thermometers, pulse oximeters. There should be baseline blood tests like CBC, electrolytes, renal and liver function tests, CRP, D-dimer ideally should be done as baseline. And if required, there should be facility to repeat these blood tests and also do ECG if required. And it's important that 0.1% sodium hypochlorite solution for this infection should be available at home. All right, so we have made all these basic requirements to be available. So what instructions should be given to our patient? So the patient should be told that he should be using a triple layer medical mask, that is an N95 mask, when anybody from his house who's not infected is going to be into his room. And if at all this mask is soiled, or if more than 8 hours have passed, then this mask should be discarded. The patient must stay in an isolation room, and he should not just be moving outside his room just because he's bored. He has to maintain a distance and stay away from other people in the house, especially those who are elderly with comorbidities. And patients must take rest, and they should drink lots of water to maintain adequate hydration. And the patient should be maintaining the respiratory etiquette all the time. The hands must be washed often with soap and water for at least 40 seconds, or they should clean with alcohol-based sanitizer when they're going to be touching around. The patient should not be, of course, sharing their personal items with other people of the house who are not infected. The patient must strictly follow the physician's instructions and the medication advice, and the patient should be self-monitoring his or her health with daily temperature monitoring and should report promptly if there is any worsening or deterioration of the symptoms. Okay, so we know what to tell the patient. What instructions should be given to the caretaker? So as we know, caretaker is very, very important, and therefore we have to protect the caretaker as well. So the caretaker ideally should wear an N95 mask with a face shield or glasses when he's going to be in the same room with the patient. What is really important is that we need to tell them not to keep on touching their mask all the time. If the mask is wet or dirty, then they need to remove it immediately, and has to be removed with the correct technique, whereby they're going to remove it from behind and they're not going to be touching the front of the mask. They have to discard the mask after use, and they should be avoiding to touch their nose, mouth, or eyes. We may feel this is so obvious, but we as medicos know about this, but normal population does not really know this. And therefore, it's very, very important that each of this information is clearly spelled out to the caregiver. Hand hygiene also needs to be explained to them, and they have to be told that hand hygiene must be ensured following contact with the patient or his immediate environment. Also, the patients are wearing, the caretakers are wearing gloves, then the hand hygiene is very important after removing the gloves. And if at all the hands are washed, then ideally they should be cleaned with a disposable paper towel. And if they don't have disposable paper towel, then separate napkins should be kept for cleaning the hands. And after the napkins are wet, they should be appropriately discarded. Food must be provided to the patient in his room, and the patient should not be coming out to eat food. The best would be to knock on the room and then keep the food and go away, and then just call up the patient, and the patient comes out, picks up the food, and closes the room door again. The caretaker must avoid contact with body fluids of the patient, particularly oral and respiratory secretions, and disposable gloves must be used while handling the patient, and there should be kept dedicated eating utensils, dishes, towels, or bed linen for the patient, and of course these should not be shared. Any additional information should be given? Yes, a number of them. The caregiver has to make sure that patient follows the prescribed treatment. It's not that the patient is in his room and nobody really checks on the patient. We need to make sure that the treatment is being taken by the patient. The caregiver and the close contacts must self-monitor their health with daily temperature monitoring, and the caretakers also must report promptly if they develop any symptoms suggestive of COVID-19. The household member should avoid entering the patient's room, and if it's not possible, then they must maintain a distance of at least 1 meter and ideally 2 meters from the patient. And of course, the visitor should not be allowed to meet the patient, because we actually have a lot of family people calling up saying, I'm the daughter and my father has COVID and can I go and see him? So of course, these instructions need to be spelled out, because there are some enthusiastic relatives who may still want to come and see the COVID-19 positive patient. Very important question that is always asked by relatives, and this is actually very, very important to them, which actually we don't end up covering in our instructions, is how do I take care of patient clothes, linen, and utensils? So basically, we have to say that we have to use dedicated linen and eating utensils for the patient. Either the patient can clean these with soap and water after use, and it can be reused again. If at all we are going to use, if the patient is very weak and if the relatives have to clean this, then gloves must be worn while cleaning them, and a triple layer medical mask should also be worn while these things are getting cleaned. And for washing the laundry and the linen, it can be either done by a normal soap and water, or it could be a machine wash at 60 to 90 degrees, and normal common detergent can be used for this. Okay, so after all this, an important question is, how do I dispose the waste that has been generated? Again, a very important question, and I would normally not end up informing them about this. So this we need to tell them that all the waste must be packed in strong bags and closed completely before disposal, and eventual collection would be done by the municipal waste services. However, the patient is in a small village, and if they're doing telephonic consultation with you, and if they don't have the access to municipal waste services, then they can actually bury the waste. Very often the patient is a woman with a child and she's breastfeeding the child. An important question asked is, can I breastfeed if I'm COVID positive and being treated at home? So we all know that the mother can actually continue breastfeeding because there's insignificant role of breast milk in the transmission of other respiratory viruses, and we all know benefits of breastfeeding, and therefore COVID positive mother can continue breastfeeding, but of course she should be wearing an N95 mask while doing this. It would be good if she wears a face shield also, and milk extraction would be better than direct breastfeeding. These are the instructions we want to give to a breastfeeding mother. Patient caretaker may ask, I have no symptoms but will be looking after COVID patient. Can I take any drugs as prophylaxis? And over here opens up the Pandora's box of a lot of controversies. So these are what the recommendations are. Everybody is allowed to pick and choose what they would like to do. So ICMR in May actually gave out a recommendation for prophylaxis, that if the health people who are looking after COVID positive patients, and if they are asymptomatic household contacts, then the people looking after the patient could take hydroxychloroquine 400 milligram BD on day 1, followed by 400 milligram once a week for next 3 weeks. Of course, they have very clearly mentioned that by taking these drugs, we are not really sure if this is going to help us, and this should not instill a false sense of security, and taking personal precautions is very, very important. Then we have this other drug, ivermectin, which has really come into a lot of news, and it's actually very, very popular in certain states other than Maharashtra. So basically the thing is that Andhra Pradesh and Uttar Pradesh actually recommend ivermectin as prophylaxis for the home people who are looking after COVID-infected patients. And the dose they've recommended is that 12 milligrams of ivermectin can be given on day 1 and day 7, 2 hours post-dinner, for those patients who are looking after COVID patients at home, and if these people are asymptomatic. Again, we really don't know because we have all the studies which are in vivo, and we don't really have much about in vitro results, and therefore what is being given is what I'm presenting, and everybody can decide what they want to really follow. Important question, which Dr. Roshni also very well covered, is what should I eat and what should I take as immune boosters? Should I have methi? Should I have turmeric? What about Ayush medicines? They sound so promising. So what I actually advise my patients is good, healthy, nutritious food is most important. Please eat what you normally eat. Homemade food, good hydration, very, very important. Lots of rest is important. You need mental rest, you need emotional rest, and you require adequate sleep. Please avoid doing stressful work, even brain-wise, and just take rest. A lot of people talk about vitamin C, vitamin D, zinc as immune boosters. We are not really sure. They could help in certain diseases to reduce inflammation and swelling. We are not really very sure, but if the patients ask for these, then I'm happy to prescribe these, telling them very well that I don't know if they work. What is really important is, when should medical attention be sought? And we need to make this very, very clear. So the patient and the caregiver should be trained to seek immediate medical attention if the patient develops difficulty in breathing, if the saturation drops less than 95%, if there's persistent pain or pressure in the chest, there's mental confusion or inability to arouse the patient, there's slurred speech or seizures, there's weakness or numbness in any limb or face, there's bluish discoloration of lips or face or fingers, or if the RR goes more than 24 minutes per rest. And this we must write down and give it to the patient and the caretaker to immediately report to us. And now the last question, when can I be called cured and when can the home isolation be discontinued? So as per the ICMR guidelines, the patient under home isolation will stand discharged after 10 days of symptom onset and no fever for 3 days. However, it doesn't end over here. Thereafter, the patient will be advised to isolate himself at home and self-monitor their health for further 7 days. There is no need for testing after home isolation period is over, and we don't really need to repeat the RT-PCR. So summing up, there are certain prerequisites for home care for COVID-19. The patient should be asymptomatic or mildly symptomatic. However, if you are experienced, then certain moderately symptomatic patients could also be treated at home. Home care is not for immunocompromised patients. Patients with comorbidities should be allowed home isolation after proper evaluation by the treating medical officer. There has to be a separate room and a separate toilet for the patient. An intelligent, well-informed 24/7 caregiver is a must. The caregiver must take full responsibility for being in touch with the treating doctor, and the undertaking by the patient and the caregiver is mandatory. So to conclude, careful patient selection, adequate education of patient and caregiver, and optimal monitoring can make home care for COVID-19 the alternative standard of care and can help us handle this pandemic better. Thank you.
Thank you, Amita. Excellent presentation. If you stop sharing your screen, great. I'll
Yes.
try and put this up. So many practical points you've brought up in this talk, which I think will be essential for so many people. I'm going to just try and share my screen. Can you see that? Is my screen visible?
Yes.
Lovely. So let's move on, and we're sticking to time, which is wonderful. So my topic is triage and medical therapy at home. What drugs can you give at home when you've decided to quarantine your patient there? Just one slide on the current Indian pandemic situation. Our first COVID case was a young girl who returned from Wuhan in the very early days of the pandemic. 30th of January seems like another century away almost, doesn't it? But it was just 260 days ago. In 6 months, we reached 1 million cases. And thereafter, we've had about 80,000 Indians infected every day. That's more than all across Europe, in fact, if you ask me. And it's the most new cases globally. As of today, we've moved from 1 million to 7.5 million as of this morning. And as Amita has pointed out, each million's rise from 5 to 6, 6 to 7 occurs in a period of about 13 or 14 days on average. At least 100,000 plus deaths, and an average of 1,000 Indians die of this virus every single day. So I think that puts this enemy in immediate perspective. And as you know, it's a spectrum of disease, and the majority of patients will have uncomplicated infections or mild infections. And look, up to 80% of patients can theoretically be home treated. This 15 and 5% you'd leave out of the equation, of course. And let's look back at the very first landmark article in the Lancet, and it showed a number of important things. First of all, they looked at 44,000 patients. You can see from the green circle at the bottom that 80% were mild at the start of the pandemic. 14% were severe, 5% were critical. Again, 81% theoretically who could be managed at home. And if you look at the bars on the top, they take different symptoms across time. And you can see that fever and cough start right from day one, generally. But you can see that breathlessness or dyspnea starts at day 7. So this is your window of opportunity. This is also your danger period when it's easy to get complacent. And hospital admission generally is soon after that at day 7. And of course, ARDS averages around day 10. Let's look at our own data from our Maharashtra site. As per the government COVID site, 70% of COVID patients in this city and across the state are asymptomatic or only mildly symptomatic and will generally stay that way. 30% are symptomatic and about 5% are critically ill and need ICU, very much like the Wuhan data. 30% of symptomatic patients need oxygen. 65% are symptomatic but don't need oxygen. So again, large numbers of patients, indeed the majority, if you exclude these two categories, can be treated at home. So who can safely be treated at home, in my opinion? those with mild disease, those with moderate disease, but low risk of progression. And we'll touch on that in a minute. Those who have no adverse prognosticators, where you have the facility for self-quarantine, which Amita has so well highlighted, a doctor who agrees to take over responsibility for care like Dr. Mashru, and those who can be relied on to be monitored for progression. But as Ravi will point out in his talk, that perhaps we can be more broad-reaching, more forward-thinking than this and include in this category of home treatment even more patients. In the early days of the pandemic, we wrote up this article on prognostic factors for adverse outcomes. And I think each of these stand the test of time as the pandemic has rolled on. If you're aged more than 55, you're higher risk. I don't like this figure because it makes me immediately at higher risk. Comorbid conditions, uncontrolled diabetes, as you've heard from Dr. Sangani, poor respiratory or cardiac reserve, morbidly obese. Every patient in the ICU, almost everyone in the ICU who's on a ventilator is generally speaking obese. Immunocompromised patients and certain lab parameters are very important. A very high D dimer, an NL ratio, neutrophil to lymphocyte ratio more than 10, a high CRP, other inflammatory markers, lymphopenia, an absolute lymphocyte count less than 1,000 is always bad news, and a very high CT severity score, by which I mean more than 15 on 25. And this is a nice graph from the CDC, which shows your risk for hospitalization if you have any of these conditions. And then you would be imprudent if you do have them to risk home care. So if you have asthmatic, you're 1.5 times more likely to end up in hospital. If you have diabetes, for example, 3 times more likely. Severe obesity, look at your risk, 4.5 times more likely. And a combination of 5 or more of these conditions, and again, 5 times more likely to end up in hospital. So the first step is to decide whether the patient who you're seeing either in person or on a video consult is a low risk or a high risk patient. By low risk, I've told you age less than 55 and the comorbidities which we touched upon. By high risk, again, I mean exactly the converse. And then you determine the severity of your patient's infection when you first assess him. Is he mild infection and you have classic symptoms and signs which suggest mild, moderate, or more severe disease? And then combining these two, you decide the level of care. So for example, someone with mild disease and low risk of progression, no comorbid factors, I'd say category A, can be safely home managed 9 times out of 10. Mild disease, but high risk. What do I mean by that? Someone who, when you first see him, looks well and has none of the risk factors, but yes, is obese, is diabetic. He instantly goes into category B, and perhaps it's prudent to admit for monitoring, maybe one of the large jumbo centers that have proliferated across Bombay, or if you are brave enough, continue such care very watchfully at home. If someone has moderate disease, when you first see him, he's breathless, he's really unwell, whether it's category A or B, risk factors or no risk factors, perhaps it's safer to admit such a patient to a dedicated COVID center, though Ravi will argue otherwise, interestingly, in his talk. And if you have severe disease, of course, at presentation, whether you have risk of progression category A or B, then, of course, such a patient needs to be in a specialized COVID ICU. And this is the dome, which I pass every day on my way to Bridge Candy Hospital, 5 minutes from my house. And this young lady, Dr. Neeta Varti, should really take a bow. She's a very, very busy gynecologist, but since COVID began, has put all her efforts into converting this. And she's taking rounds with me here at the COVID center on Sunday into this huge complex, extremely impressive when I saw it, of 500 beds with oxygen for almost all of the beds, with 50 ICU beds as well. And you can see on a central monitor, ICU patients being monitored. And this is again, perhaps a facility in between home and hospital where our patients can be monitored, especially because beds are so hard to come by. What about scoring systems? Will they help you triage your patient when you first see him? Make it more easier to stratify the level of care appropriately instead of vaguely saying mild, moderate, and severe, which is so subjective? Well, we have a number of robust scoring systems. Chief among these must be the National Early Warning Score, the NEWS2 score, which is adopted by the NHS in the UK. There's an app which any of you can download. You punch in your parameters like your respiratory rate, your saturation, your pulse, your temperature, and you come up with a score and a risk, and you know what would be appropriate level of care depending on the score that you get. There are three other parameters or systems. There's the CURB 65, which chest physicians know as a pneumonia scoring system, the new score we spoke about, and there's a SOFA score, which is the severity of organ dysfunction score, which intensivists know. And when these are compared and put to the test, the new 2 score seems to stand out best. It predicts a poor outcome in 72 hours with a sensitivity of 92% and a negative predictive value of 98%. So really, if Dr. Mashru wants to be very precise about whether it's safe or unsafe to keep seeing his patient at home, he just has to punch in the new score into his phone. This is a new score called the 4C mortality system, just out in the BMJ a while ago. Again, you can stratify into low, intermediate, and high risk. And this has very robustly stood the test of time. As the score value increases, the probability of death increases in almost a linear fashion, and quite easy to measure variables have been looked at. Let's move on to drugs at home. What do you use when you decide to have your patient and look after it at home? And equally important, what should you not be using? So this is a typical prescription. This is from a consultant. I've removed the name except that he's an MD. And you will see prominently featuring on this long list. Look, I've always been a physician who believes that less is more. The fewer the drugs on your prescription, generally, the better a doctor you are. So I see 3 drugs which make me really upset and often angry: ivermectin, doxycycline, and HCQS, because I do believe that these drugs really have no role in the management at home or hospital or anywhere in COVID patients. And when such recommendations get government approval, it makes me even more infuriated. You can see for all, for example, hydroxychloroquine, promoted by MPs in the government with a WHO stamp. WHO would be turning around its axis in Geneva if it saw this. But along with a very bright colleague from Harvard called Sachit Balsari, we wrote this in the Indian Express, I think it was, what not to use at home in COVID-19. And I'd like to plaster this across the posters of Bombay. We said, don't use antibiotics, except, of course, in a very sick patient who's septic in the 3rd week of illness. Don't use HCQS, ivermectin, or seltamivir, which is a drug used for influenza, and ribavirin. And I like this quote from Vinay Prasad in Medscape, who said, for a sick patient with any other viral illness without proven treatment, I have never witnessed doctors giving 5, 6, or 10, as you saw in the prescription I put up earlier, drugs to treat the virus without any proof that it will help. Let's not lose our sense of science and objectivity, as Dr. Mashru said. I've never seen a severely ill patient with influenza, for example, or HIV, for example, receiving vitamin C, zinc, HCQS, tocilizumab, all without evidence. With COVID-19, however, the primary rule of medicine, first do no harm, appears to have been discarded. And there are recommendations after recommendations against using drugs like ivermectin, drugs like HCQS. As this recent editorial in the Annals said, the saga of HCQS must meet its sad end. It's time to move on. And even 2 days ago, of a drug in which the international community had invested so much, not just financially, but in terms of hope. We were part of the WHO solidarity effort, a mega trial of great significance because it included more than 400 hospitals across the globe, 30 countries, 12,000 participants, a robust trial. And it showed that despite the hype, remdesivir did nothing more than placebo in ending the coronavirus pandemic. And the data was looked at very, very carefully, and we expect a New England Journal publication any day. So what drugs would I be happy to use or recommend that all of you in the audience use in the home treatment of your COVID-19 patients? Well, consider favipiravir, and I'm using my words carefully. Consider steroids in the right patients, anticoagulants, and oxygen. So favipiravir, and I've got about 200 questions which have been rolling in on my iPad, and most of them are, what about favipiravir? Well, let me run you quickly through this drug. It's an experimental antiviral drug. It's a repurposed drug which had been used against influenza in Japan, and China and Japan have stockpiled millions of courses of these drugs for potential influenza outbreaks. It's not yet FDA or EU approved, and our colleagues in Europe and the US will not be talking of this drug, at least at present. It's got a broad spectrum of antiviral effects against influenza and RNA viruses, including Ebola, in which it was put to test. It's oral, it's moderately priced, it's safe, it's easy to mass produce off patent, and you see hundreds of Indian companies have jumped on the bandwagon, and generics are now possible. It's probably most effective in the mild to moderate case, but reserve it in someone who's symptomatic. But the disadvantage seems to be the high pill burden. We wrote up a review on this drug a few months ago, and I am concerned that the actual available data is a bit thin, but that is changing. And this was a recent publication in a very prestigious high impact factor journal, which showed that taking the drug did result in a significant improvement in fever and time to clinical effervescence, but no change in viral load. Our publication, our study on the virus, on the drug in 10 Bombay centers is under review in a journal abroad. And all I can say is that all the drug can do is perhaps get your patient well a little faster, shorten the clinical time to improvement, and don't expect, of course, a cure. Some pointers if you are using this drug, and I'm going to answer really most of the questions that have been asked. Really. If you're using any antiviral, like I guess if you're using any anti-infective antibiotic, start early. When I say early, it doesn't make sense to use an antiviral after the first week, and certainly not after the second week when your viral load is very, very low. Give the correct loading dose, which is often not done. Complete the recommended duration, which is 14 days, but perhaps shorten to 10 if your patient is doing wonderfully well. Monitor the uric acid, the LFT, and the creatinine, and please bear in mind that it's unsafe in pregnant or lactating females. Let's move on to steroids, because again, like Solidarity, recovery was a wonderfully conducted University of Oxford and NHS pragmatic, randomized, controlled, adaptive trials. That's what all these big trials are. They adapt to emerging data. When a drug is proven not effective, they remove it from their data analysis and start looking at new options. And this was the date at which we had the first drug which affects the mortality and the outcome, and I use those words carefully, and it remains the first and only drug in coronavirus. This was the NEJM publication, large numbers of patients. This was the dose that they received, and the results were pretty dramatic, I would say, because these are considered extremely impressive reduction in 28-day mortality rates, and the use of this drug would prevent 1 death of 8 ventilated patients. And bearing in mind that this drug is almost as cheap as a glass of water or roadside tea, you really have a potential winner on your hands. And based on this data, the trial was stopped, and suddenly DEXA became the standard of care. It's the first and only life-saving coronavirus drug. It's cheap and widely available. These are called forest plots, and you can see the diamond of significance clearly favors the use of dexamethasone across most, but not all categories. And this is a very, very important proviso I need to bring up. In patients who are getting no oxygen, in patients who do not require oxygen, but who you give the drug to, as occurred in the trial, you actually had worse outcomes than in patients who are requiring oxygen. So this was very important. Look how dexamethasone reduces mortality in patients needing ventilator in this panel. But look at this panel here. When oxygen is not required, dexamethasone actually seems to worsen outcomes. It's not a DEXA-specific question or effect. And again, I've been asked this question by lots of people, so I'm answering it here. It applies to equivalent doses of any steroid. So this equally important REMAP-CAP COVID study showed that hydrocortisone, again in a modest dose, 50 milligrams 6 hourly for 7 days, results in 93% probability of being organ support free at the end of 3 weeks. Paul Sachs is a colleague at Harvard who said it's hard to imagine not offering DEXA today to a patient with COVID-19 who needs ventilation or oxygen. They might live longer, and that's good news. but don't take steroids in mild cases. Don't take them early, because in the early phase of your illness, your immune system is your friend. It's your only friend. It's fighting the virus, and dampening it with steroids may just not be a good idea. So these are very recent, from yesterday, NIH guidelines. And if I looked at the steroid guidelines for patients at home or those hospitalized but not on oxygen, this panel of experts recommends against using dexamethasone. I can't be more categorical than that. Moving on to anticoagulants, thrombotic microangiopathy is one of the pathological hallmarks, and you can see these green arrows pointing at small vessels which have been clogged up by thrombi. It's not just a big vessel disease with clot in the veins and arteries of bigger vessels, but you get a microangiopathy involving the small vessels. And COVID-19 is really like a serial killer with two bullets. The first one for the lung, which we focused on at the start of the pandemic, and the second for the vascular side, heart attacks, strokes, and other vascular problems, DVTs, pulmonary embolism, which we're seeing with increasing frequency. And when in an idle moment I punched into Google blood clotting in COVID-19 patients, look at the number of hits I got, 2.5 million. And an example is this study from Circulation, which said that DVTs were noted in as many as 85% of COVID-19 patients in a Wuhan ICU. This was in the early days of the pandemic. Many patients were already on prophylactic low molecular weight heparin. And that is a startling figure, because we do know ICU patients are more prone to clot, but this really is taking it almost to extreme. As far as anticoagulants, if I could put up a learning slide, have a low threshold for use of anticoagulants. At home as well, I would say, if someone is obese or has other risk factors for DVT and PE, I would certainly recommend it, but be guided perhaps by your D-dimer, which has the highest C-index predictive value of any in-hospital mortality tool. And if you are more than 2 on your initial or more than 2,000 in some labs, in your D-dimer, it will predict in-hospital mortality with pretty considerable and scary sensitivity and specificity. In hospital, all my patients are on low molecular weight heparin, mostly once a day, but some twice a day. And at home on discharge, most of them or many of them are discharged onto apixaban, which they take for a variable period of time. But again, lots of data is needed to answer important questions here. Let me end my talk with a case presentation, which exemplifies really the good and the bad of treating someone at home. It is a hair-raising task. It's much easier to say, go to hospital, less responsibility, but let's look at this case and learn. So she was a young homemaker with no comorbidities. The typical presentation, 1 day of fever and sore throat in Bombay, all of you know means COVID, unless proven otherwise, especially if some family member had just tested positive for it as well. She consulted her family practitioner. No, it was not Dr. Mashru this time. And he involved me, the family practitioner that is, for further video guidance. And on the day 1 of illness, she had none of the adverse prognostic parameters that I talked about, none of the clinical ones, none of the lab ones either. And my assessment was mild disease, no risk factors, therefore category A, safe to continue home treatment. And what was my home treatment recommended? Symptomatic treatment. Paracetamol, anti-allergics, nothing else required. But at day 3 of her illness, her fever was still spiking and high. Her CRP had gone up. The chest x-ray was starting to show some shadows. And my advice at this stage was, we have an oral antiviral which has been shown to reduce the period of viremia. Let's use it in the correct dose. That was her x-ray. And you would agree that this lady at home was developing a bilateral pneumonia. Day 3 to 6, we were feeling pleased. Fever was settling, the cough was okay, saturation stayed okay at this stage, and we continued the favipiravir. Now, fever, when it prolongs beyond 7 days from the onset of illness, in my mind, is a very worrying symptom. And those with prolonged fever are more likely to require ICU admission, and patients with prolonged fever also generally have higher inflammatory markers. Day 7, as you know from my first slide, is your most worrying day, day 7 or day 8 of your illness. Even a patient who starts off as normal as this one did on day 1 can worsen at this stage, as she did, with her fever recurring, always bad news, her cough worsening, this time accompanied by streaky hemoptysis, telling us that the virus had clearly got deep into her alveoli. CRP had increased, D-dimer had increased, and then that most red of red flags, so to speak, her saturation going down for the first time. 92% at rest, falling to 89%. And of course, total panic happens and ensures at this stage. Panic not just for the family, but for the doctors who have agreed to take on the onus of home care. Would you hospitalize or would you continue home care? Well, no bed is available, of course, when you most want it, at least at the two hospitals I'm attached to. And the patient and family really had no option but to continue home treatment. And so we continued the favipiravir. Certainly remdesivir cannot be given at home. And I wonder if I would even consider using remdesivir anymore after Solidarity data has come through. I commenced her on dexamethasone 6 milligrams because I was convinced that she was brewing a mild cytokine storm, getting more hypoxic, the inflammatory markers going up, the CRP, the D-dimer rising. I added an antibiotic, azithromycin, really just to cover tracks. No evidence that she had a secondary bacterial infection, but they can set in, especially in the second and third week. Anticoagulation because her D-dimer was high. And we commenced oxygen at 2 liters a minute. Fortunately, she had it in stock because an elderly family member had been using a concentrator for his COPD. We encouraged self-proning. We asked her to start breathing exercises. And fortunately for all of us, her fever settled. And I think these are just the interplay between the virus and your immune system. I don't think we can take any credit for patients' recovery in this one disease. Her saturation became easy to maintain on just 1 liter. Her WBC count was slightly high with the lymphocytes rising, probably because of the DEXA. Her parameters settled. We could stop the antibiotics, the antiviral, the oxygen, and everyone was relieved and happy. But in this disease, it's not over till it's over, because our final telecast was at day 25 when she said, "Doc, this is the worst I've felt in all 30 days. Fever coming back, or feverish feeling at least. I've not slept well for a month. I have complete anorexia." She was suffering from the post-COVID syndrome, or the long COVID syndrome, like they call it in the UK, with an array, a constellation of obscure symptoms, which doctors in the past laughed off as post-viral fatigue syndrome. But when those same doctors came down with it, they realized the gravity of these symptoms, at least in our patients' minds. They're persistent, they're worrying, they may not be dangerous. And this was a wonderful article from the ERJ, which showed that these symptoms persisted at 3 months after this infection. In 113 patients in Holland and Belgium, recruited interestingly via Facebook, 55% have 3 or more symptoms 3 months after they are through with their COVID. And this figure I found most startling, that less than 1% call themselves symptom-free at the end of 3 months. And you can see here that only 7% say they had good health status. That's the green curve, which is what they start off with. 90% of them is only 7%, even after a time lapse of 3 months, and only 0.7 are completely symptom-free. So to summarize, my 10 principles of home care are: know who it's safe to treat and who it's not safe to. Take on the responsibility of patient care only if you have the time to carefully supervise them. The only predictable feature of this disease is its unpredictability. I've burnt my hands so many times, I've stopped even pretending I'm an expert. So be prepared. Few, if any, treatments of COVID-19 have been proven to be effective, yes, including remdesivir. Use drugs which have a strong evidence base. As your knowledge advances, so should your practice. Avoid the compulsive prescription of drugs because our patients expect it. That's not a good enough excuse. Polypharmacy deserves to be condemned. The majority of these patients can be managed at home, and a healthy immune system is your best defense mechanism. Please support it. We've talked about drugs doing more harm than good. Monitoring is essential. Use of technology, as you've heard from our previous speaker, but don't become a slave to it. There will come a time when you need to actually go and examine your patient, and please don your gloves and mask and do it if that is what the situation demands. And I've talked about how your responsibility continues even after several weeks are over, because the long COVID syndrome is very real. So you need a patient who's intelligent and motivated, a doctor who's committed, a family who's supportive. You need the right drugs and equipment. You need constant monitoring of the kind that Dr. Mashru can do. And many people don't have the time and the inclination to do if home care is to succeed. And let me end by quoting this great man who deserves a lot of credit just for standing up to Donald Trump, as he does at news readings every day. He says, I've never seen a single virus, one pathogen, have this range. 20 to 40% of patients have no symptoms. Some get mild symptoms. Some get symptoms enough to be at home for a few days. And some are in bed for weeks and have symptoms even after they recover. Others go to hospital. Some need oxygen. Some need ICU. Some get intubated. Some die. So all this with one pathogen must be unique. And this quote from Albert Camus from over 75 years ago always continues to move me, because it shows how completely unprepared we were for this pandemic. I'm going to stop sharing and first apologize, because as your chairman, after cautioning you to be on time, I have crossed that time limit by 5 minutes. So apologies. I'm going to stop sharing the screen. And it's going to be my pleasure to introduce my dear friend from Bangalore, Ravi, who heads the Apollo Hospital Pulmonary and Critical Care sections. Ravi is a gifted speaker, 75 plus publications. Ravi is a nationally and internationally famous invasive bronchoscopist. He makes complex hair-raising procedures look easy. Perhaps that's why he's taken on the mantle of seeing if patients with COVID can be treated, not just with drugs and quarantine, but extending that level of care to oxygen as well. So Ravi, I've really been looking forward to your talk. Welcome, and sorry for crossing my time by a few minutes.
Well, thank you very much, Zarid. Can you guys hear me and see my screen?
We can.
Okay, lovely. Well, as usual, amazing, stupendous, comprehensive, and thought-provoking talk, Zarid. And one, I have to thank you and Albert for calling me on this screen. But I do have a few peeves which I'd like to put in the beginning, just like disclaimers of medications, which you so adroitly pointed out. First of all, I get to follow all these lovely speakers who are acing it in their own right. Secondly, I get to follow you. And thirdly, I get to take on a topic which anyway, everybody seems to be smiling and snickering in the background as we try to take it on in a very unusual platform where nothing seems to be working. So with this nice advantage to my credit, we will start on this particular agenda. And I have retitled it so that I start the discussion in a very thinking way. Is that, can oxygen be given safely at home to the hypoxemic COVID-19 patient, which you mentioned? I accepted in the beginning, and as the days have passed by, I have slowly regretted it to the point today where I completely was sitting with my head in my hands, as you must have been after seeing the Solidarity trial. But nevertheless, we will go and try and do justice to it, because certainly a lot of work has been done in this field. The name of this concept is COVID hot therapy, home oxygen therapy. So those of you who think the title is interesting and fascinating for a morose and despairing topic, understand it's just an acronym. And we have titled it as a flight of fancy or a provocative idea which wedged its way in, as has happened in the COVID pandemic. So today's flow in the time given to us is the need for oxygen, very standard, everybody knows that. The statement of need of this particular concept, how did this question arise? And then comes the most important thing we're asking. If we took around 8-9 months to look at repurposed drugs and try and question them, then we have to look at where we consider our mecca of care, which is a hospital. And we ask this question as we have put in the screen. And then we talk about out-of-the-box innovations in India. And here I seek forgiveness from you, Zarir, as I weave a tale. But since everyone's weaved a very nice tale, I think I stand a little absorbed. And I leave a quote which I will perhaps reuse later, that desperate necessity is a mother of unthinkable innovations, which sets the stage for this topic. Of course, we cannot be all rhetoric, as you have rightly said in your talk. So we need some data. And then we'll analyze the entire talk and summarize the whole the talk in the time we have over here. So it's not difficult to talk of this particular aspect. When is oxygen required in COVID-19? And we have many of these recommendations. In fact, you get probably inundated with the numerous recommendations, some of which are redundant. At the same time, you are compelled to see them because some of them may be regulating your state laws, as Anmita was pointing out. So clearly here people say that when your oxygen starts to fall, and that is variously talked about, you need to give oxygen to maintain a target of 92 to 96%. And even this is being questioned now with two complete different sides, where one side says maybe more and one side says less. And the Indian government got up, especially in Karnataka, where we had a hue and cry that we don't have oxygen, for God's sake, start using less compared to more. So anyway, this was the guideline which came over there. Awake proning seems to be the phoenix which rose from the little areas it was used in, and it became one of the most common things, easy to talk about, no cost at all, just needs effort and convincing. And then, of course, came the rest of the stuff, which is part of routine COVID monitoring. Bottom line is people who desaturate should be getting oxygen, and of course, they should be looked at more carefully. And then we look at the WHO, which has gone through various stages. Its initial role as a world manager or world observer for COVID has been questioned, the way things were done. And then the statements made and the statements retracted. And then its attempt to come back by doing all these studies such as solidarity and trying to make sure that we have the right data on the ground. So the WHO's role itself has shaken, much like COVID has shaken the whole world over there. WHO also says that by and large 90 is your trigger, and understand that this is the ease which is given to you. Understand that a saturation of 90 in the world of what's called PO2 or measurement of arterial blood gases corresponds to any PO2 of anywhere from 40 to 110. So we really don't know whether the number actually reflects what we want to look at, which is circulatory sufficiency. It actually just reflects a common number which can be given, measured by instrument called a pulse oximeter, which may be anywhere from made in China to made in Japan. And you have to rely on that as being one of the single most important indicators to decide on one of the only therapies left to have any life-saving importance, which is oxygen therapy. I mean, besides the steroids that I talked about. So understand that the whole science is slightly flawed, but for the purpose of practicality, this has been put out there. And so all of these guys recommended or implied admission. You can't do this at home. But of course, it was the biggest gap between proclamation and practice happened when a whole deluge of patients descended onto our woefully unprepared hospitals. And that is when we started to see more problems, and problems we never saw before. And this is what actually happened over there. And these headlines, which I have picked from the internet over time, reflect the story of COVID, which is absolutely horrific, sad, and ultimately regretful as we realize what a job we had done over there. And it started early, as you guys in Mumbai, unfortunately, were the opening batsmen in the whole COVID pandemic. And you can see such headlines became more and more common, where people were dying over there. And of course, there was always some encouraging note that the municipal corporation is going to get its act into shape. And then came the next headline. This is May, as you can see in a newspaper, that Mumbai runs out of hospital beds. So clearly, as Amita rightfully pointed out and Zari reinforced, it's not easy to say, okay, lovely, get hospitalized as we used to do before. These hospital beds were on a premium as never seen before, with stakes never imagined earlier. Then, of course, came the more horrific aspect, which we may have seen in training, but that was an occasional thing and never to be talked in a pandemic, as we tried to reconcile this social distancing gaps and all sorts of precautions with what was happening. And sharing beds seemed to be the most horrific thing which could hit any headline and make your blood curdle, as you see that this is pretty much saying you might as well consign patients to the grave before you even give them a chance. And then, of course, this spread to Delhi. And Delhi, as it was watching with all its wisdom and all its resources, was watching Mumbai, seemed to learn little. And I will reiterate this paradigm that each city seems to have functioned in a silo, and then the subsequent city seems to have learned scant or nothing, to put it very crudely, from its sister or brother concern. And here New Delhi sees the same thing over there, and the hospital bed story is again repeated. You just change the headline from city to city, month after month. And then came finally Karnataka. So our city and our state was actually lauded for being lovely, great, stalling the COVID pandemic, doing all the right things. But I think anybody who has taken credit and sits gloating in the COVID pandemic must eat humble pie. That has been the unfortunate story, whether it's been drugs, actions, thought leaders of the world, or the like. And so in our city also, we started to see this, and we should have been prepared. We saw it after Mumbai and Delhi. We again had our death deluge. And finally, again, the same thing, that people are struggling, people are dying on the street, and so on and so forth. Finally, you can see the date now. I've moved from March to August, a span of 5 months in less than 3 minutes. Private hospitals ultimately launched innovative plans. And then came this magic word called home assessment, where finally the system, the government, the centers accepted that the patient should be assessed for home care or require hospitalization. An extremely compelled strategy, which was logically present everywhere in the world, but we had decided to wear blinkers as we saw the pandemic go from city to city, even in our country. So the situation was a mess, and many minds started to think as the death roll of COVID continued. And it has actually been a travesty to humankind. We've talked of Rwanda and all those things, all those countries being genocidal. And I think somewhere COVID-19 strategies, thought processes, actions, and ultimately on the ground results would reflect a similar result. Money and power could not get you a hospital bed. And as we're looking at Mumbai being very close to our hearts, a lot of us studied over there. Can we do something for these patients till they get a bed? Is there any point that they run from hospital to hospital, emergency room to emergency room, and they go from saturations of, say, 85 to 70 to 60? And even if you get them into a hospital, with all what you do for them, they ultimately die. So then the big question came on, which has been partly addressed, actually overwhelmingly addressed by my last two speakers. Do all patients actually need the hospital bed? Can we evaluate what is the value addition of the hospital? And this is a core question we have never asked ourselves, as we are intuitive practitioners who decide that we know by our sixth sense and our large amount of experience and knowledge and papers that who needs to get admitted. We never ask ourselves that when we put a patient in a hospital, what are we actually doing? Amita mentioned the fact that they are completely, for the first time in existence, devoid of any family support. So is our actions, which include non-medical medications and others like instrumentation intensive care, actually doing something? So this sort of soul searching is something we don't like to do, but it started to become part of the thought process as we said, okay, let's think now, because clearly what we are doing doesn't seem to be working, and it's not us in India, it seems to be the whole world. The only thing is we don't seem to be networking enough to be learning from other people's experiences and implementing them in our own particular setups. So we came up with this, we just crashed ahead and a few of us were talking, and my colleague and friend and Zarir's friend too from Hinduja Hospital, a nephrologist. And clearly, as this particular forum also demonstrates, COVID has not been the prerogative of any one field. Anybody and everybody who has a decent background, medical background, thinking prowess and application and commitment can add to it. We then put our mind together and we said that can we do point of care or home-based care, which would be a paradigm shift. And this reflects part of the home care paradigm, which my two colleagues were talking about. But my area of discussion is oxygen. But I will be taking it in the context of a major program. So this is what we talked about. And my colleague also at work was very interested. And we started to look at this very carefully. And so we put a plan out there where we looked at the data. And Zarir had pointed out the fact that, of course, a lot of these patients don't require aggressive therapy. But let's look at it a little more provocatively. This was the problem statement. People running around in panic, fear, and thinking for that the emergency room or the hospital is going to save their lives, and not so. The delay in reaching them, the shift from center to center, the fatigue of healthcare, the helplessness of healthcare was actually one of the major reasons that these people were getting delayed for the vital minimalistic care, including oxygen, which should have saved their lives potentially. Then the data across Maharashtra showed that even if you admit them, you're not doing much over there. We talked of value addition of hospitalized care. In such a situation, we are only giving them simple oxygen, meds, as is now being pointed out, we don't know work or no. So what are we actually doing? They're sitting on a bed out there. They're getting oxygen therapy. They're getting medications which we don't know work at all. There is hardly any monitoring in the PP spectrum. And those of us who go in these hospitals will, unfortunately admit that the care can never be the same as non-COVID times. and then ultimately they're eating food which also may not be Roshni standards, not even remotely close to it. And so what are we ultimately doing there? And so the whole question came down that can we take a good deal of these patients and manage them in an environment such as their house, which would be way better than what we are doing, and this is the largest slice of humble pie than we can take. So we came up with a proposal for actually policy makers, and we said that why not shift the care using all the technology tools which have jumped up and sprung up in the COVID paradigm. Why not have an e-consult with an expert anyway who's not doing much work at this point, and above 60 anyway, more than 90% had decided to take a break when it came to active COVID care. And then we mentioned things like, which I won't go into details at this point, basically make it point of care. If I can pick up a telephone, a smartphone, and get in touch with somebody who in a standardized platform can deal with my issues, assess me and advise me, we may be able to avoid this deluge of patients running around and not getting hospital beds. In that, we incorporated what is the topic today, assessing the need for oxygen therapy. And if the bed was not available, can we go the next step in this COVID pandemic when nothing is working, and plan oxygen at point of care, similar to what we have done for so many pulmonary patients over the years, and then continue all what my colleague said, proactive monitoring, a plan for them, giving them oxygen where they really need it, and not making them run from place to place and die in the process. And of course, prone position, which you and I take for granted, is not known to the common patient, and walking them through as an adjunct to oxygen therapy or pending oxygen therapy certainly will make a difference, was the proposition. And so this little graph, which I'll not go into detail, pretty much said the same thing for a policymaker to try and understand this, where we said oxygen requirement assessment and providing them oxygen at home in case you don't have a bed or you're waiting for a bed is smarter than running around center to center, hither and thither, trying to get your hospital bed, which is not happening. We also put another provocative idea out there, which was the big thing, that can we have a centralized bed listing and allocation system? Then these patients, while they're waiting at home and we're going the next level of giving them oxygen so that they don't go here and there, will then be prioritized on that. And if the bed comes up in a first time, God truthful, honest system in our country, we'll be able to triage them and give them the bed, as against my brother, your uncle, or somebody else's grandfather who basically knows the trustee or has a government pull or looks like he's part of the socio-political hierarchy of this country. So that was we promulgated out there, and believe it or not, ladies and gentlemen, it has happened in a good deal of the cities. Where Mumbai ultimately has it, Karnataka had, and Bangalore has a very robust bed allocation system. But this was put forward out there. If all these can be put together, then we may be able to impact on COVID mortality much more than the medications we want to believe in and the therapies which are not working at this point. We knocked on many doors with these ideas. All of us, and Zarir has been very helpful in that. And we put it in the public space also. And the multiple doors we knocked on were endless. The Mumbai task force, where Zarir got us a foothold, who gave us a patient hearing. The Tata Trust, because we believe Ratan Tata's WhatsApp saying that I will give my life for this country would be there. The Mahindra Foundation, Predai, who's the real estate big honchos who control thousands of crores in this country, Niti Aayog. And in our own state, when it hit us, we knocked on the Infosys Foundation. I have personally met the Karnataka Deputy Chief Minister, put my idea in front of the Karnataka Expert Committee, which later incorporated us, but at that time we were outsiders. We went to the Secretary of Health Karnataka. Many, many doors were knocked. And ultimately to put it in the newspaper, because we believe that media will act more than a randomized controlled trial at this point. Jatin and I put this managed to get the article accepted in one of the leading newspapers, who saw this idea was provocative. Finally, when we were close to saying, okay, this is not going to work, maybe things don't work in a pandemic the way you want to. And of course, the fact is, let's understand that most of the policymakers are more bureaucrats than clinicians. It was, we took a backseat and concentrated on the work. And finally, an unexpected knock on a door after so many emails and efforts. And this is what the knock on the door was. One of our local members of parliament called Tejasvi Surya, young 29-year-old, actually approached us one day, and then this plan was picked up, including the oxygen component, which we are supposed to talk about today. And he put a bunch of young people here, and all of them are basically startups. Bangalore is known for startup leaders in their own right, Practo, and so on and so forth. Many of these guys. and they worked tirelessly for 3 weeks with the usual WhatsApp group chattering day in and day out, with me unable to keep up with their enthusiasm, but being the proposer of the idea, had to do that. And so finally, this came out as COVID Raksha, which was also tabled in Parliament as this young MP went and talked about the efforts made in our country and our city. And you can say this office basically got so many of these guys together. Swast is a digital platform you guys must have heard. It was the biggest ventures which came from our IT crowd over here with unrestricted grants. Project Step One is a bunch of doctors who are doing day in and day out voluntary duty. Portia rose to the occasion. It's a home care provider, and they agreed to give these oxygen concentrators. The oxygen component was the most challenging because clearly receiving a call, these guys can do. Giving service, these guys can do. Project Step One had a whole bunch of doctors who were regular, allopathic doctors. But oxygen confused them because this had never been seen before. So that was something which was also provocatively and interestingly added to the algorithm. No idea walks alone. I believe that obviously necessity, as we said, leads to so many people rising to the occasion. I was talking offline to Zarir also, who mentioned how people are asking him, apartment complexes want to run, small isolation beds, to the point of even some intensive care beds in their particular clubhouses and so on. And meanwhile, Zydus, one of the companies, came out with this particular scheme where they said, we can give you oxygen. And I called the Zydus people to get data from their success over there. This is the sort of numbers they did. And they managed to give a decent number of people home oxygen in the time they required. And as Zarir showed, many CCCs planned oxygen, and which is done all across the country. The oxygen requirement in the country has gone up 5 to 10%, ladies and gentlemen. 5 to 10% increase in the concentrators, cylinders, and the likes sold in our country after this particular awareness came over there. And the privately stocked concentrator cylinders is innumerable, and it'll be interesting to see how many of these come back into circulation after COVID goes away from the scene. Then comes the literature aspect. Is home O2 an alien concept, or do we have something going on? I always believe that when you're thinking of an idea, there's always people in other parts of the world who are looking at the same thing. It's like a cosmic phenomenon, especially in crisis. And simultaneously, as we were pushing through right from May through July with our idea, came this paper, is home O2 for a concept we should think about? And this was a collaboration of the Futuristic, who was working on this. They came up with a guideline that included people from everywhere. You have UK, you have Europe, you have Netherlands, Italy, all those guys who suffered. You have the United States of America, all of them were there. And peculiarly, I noticed that the sixth name out there came from SUNY Downstate, which is my medical, my residency program in the United States. It was uncanny when I saw this name in this particular paper. What were the highlights of this paper? In the amount of time we will not dwell on that at length, and we'll be happy to pass it on to anybody, or the slides if anybody wants to see them. They introduced the concept of short-term oxygen therapy and said that yes, it can be used in COVID, and HOT, which is home oxygen therapy, and STOT can be done with as long as you put processes and thinking and safety mechanisms into place. And they put a big statement out there with all sorts of headings, which I will not dwell on, but they went through all the checklists of what is important, from the rationale to the point of capabilities. And it's so uncanny that the same term had been used by all of us when we were trying to push this concept. They talked of risk assessment, which my colleagues touched on. They talked of initiation of home services and oxygen therapy being an important part of it. They went on to expound on community management, and they, of course, put a high concept of a specialty follow-up team. Zarir mentioned the need to follow up regularly. And then, of course, the instruments were talked about at length. And so these guys have put a very comprehensive document out there, and such algorithms are put over there. And how are you going to do it? How the home oxygen team is contacting the patient? Whom do you decide to keep at home? Whom do you decide to get into the hospital? How are you going to look for the guy who worsens? And all the questions anybody will ask when they think of this with horror in their eyes. And they came with very interesting tools, which was even revealing to me when I was reading it, a breathlessness screening tool, which seems to be a surrogate for oximetry too, where they say that if you count on a single breath less than 7, or time between consecutive breaths is less than 5 seconds, it is 90% or less with sensitivity of 87% or so. Very, very interesting. So a whole bunch of prior literature, clinical algorithms, safety mechanisms, and systems were attempted to be espoused as the way home oxygen therapy should be done. Now let's come back. We are India and we have to look at what happens in our country of 1.2 billion, 4 Americas and 20 Italy's. Is this possible at all? Well, the buy-in is possible only when we believe that this is important and the need is there. And that is when the system takes charge. Multiple stakeholders, including us and most of my co-healthcare providers, is going to smile and say, this guy is off his knocker when he talks this way. But clearly, you understand that the need came from the fact that people were dying on the streets despite having resources because the hospital bed was not there. And of course, economically, which is important, but not the main thing, does matter. But if you don't give people a sense of safety and don't define the criteria and don't make them feel that they can care of, this is never going to work. So what actually happened in our country? Well, we suffered from absolute primitive, primordial, and Paleolithic emotions, which none of us can deny happened to each one of us sometime or the other. Fear, panic, sudden deterioration. The word cytokine storm has been more of a storm than I've ever seen in my entire COVID experience, frankly, and we're still looking that carefully. Hospital bed became a premium entity. The bed, which is so important a resource, got demoted to what if I get worse and I don't get a bed? Let me plant myself over there. It became like basically a savings account more than anything else. In the process, genuine patients did not get the bed, and the precious, limited, sparse, and scarce healthcare resources and PPE went towards the one who did not need it. The biggest exercise of malutilization, which has been probably done this year and probably the history of any healthcare efforts. The home O2 paradigm has happened in part, whether believe it or not. It happened where beds are not available, and each one of us has had to somehow make sure these patients got temporary oxygen, STOT. Patients chose not to come to hospitals, and a whole bunch of elderly malignancy guys and patients who are sitting moribund, Parkinson's, neuromuscular, with savvy families and aligned healthcare providers agreed to do that. Sorry?
25 minutes over. So.
Oh, sorry, I'll just finish in a minute. And so de-escalation from the hospital became the next common thing also. So ultimately, Zarir and Amita have showed that if we plan it, whom do we do? And clearly, the patients who are unstable should not be getting it. And in a confessional aspect, as I said, that we've had it in a limited way for the groups which we talked about. So to summarize the whole talk, HOT or home oxygen therapy is provocative. It has it has a good deal of traction in the West, and a lot of organized systems are talking about it. Few takers in India with minimalistic application, which we talked about, and a concept propounded ahead of its time in India, maybe can be planned more systematically. A natural corollary from a system point of view, but few takers when it comes to fear, panic, worry, and I need the hospital bed. I end with this particular paradigm. What we have discussed is out of the box. COVID has been the impetus for innovation. Desperate necessity is the mother of unthinkable innovations. If we can have an ICU this way, I mean, look at us this way. We've learned to wear masks for hours together as we never planned, done procedures using gear, which none of us know who's there behind, and still have to do it for safety. We can certainly acknowledge the fact that when all hell breaks loose, every out-of-the-box idea can be given thought. I end with my title, COVID HOT concept is a flight of fancy or a provocative idea, but it did wedge its way in. Thank you very much for the close attention, and apologies for the overshooting. I will stop sharing my screen.
Ravi, excellent talk. This has really been your proud baby, and you've carried it through almost to conception. Keep going, because I think it's a concept which is really needed. Now, we've got, without exaggeration, 200 plus questions which have come through, and the number keeps increasing. I'm going to ask each of you a few questions from the audience and request you to just answer in a line or two, no more. So Ravi, first to you. I know this is from me, actually. I know this sounds like a sci-fi horror story, but do you think we can reach a stage where we literally run out of oxygen? Or is that just a dystopian, futuristic sci-fi horror movie? Actually running out of oxygen in terms of concentrators and central oxygen in hospitals.
At the current load of COVID, and I think today we can proudly say we're not going to overtake the US in today's statistics. We should be okay as we opened the borders and India became one country when oxygen is going from one area to the other with judicious use and appropriate utilization.
Great. Amita, question for you from Dr. Lenin Singh. Very practical question. He said, not all Indians are wealthy. Some have small flats. How can we talk and how do we proceed with home quarantine when a patient is keen on this in resource-constrained settings, when the whole family lives in a room of one?
Okay, so the thing is that very often it may just so happen that every person in the family is infected. If this is the case, then if they are stable, they all could be actually treated at home. In that case, the question of separating them doesn't really arise. But if we have people who are infected and we have people who are not infected and also asymptomatic, then we definitely need to separate them out. And therefore, the patient will have to have a single room, will have to have an attached bathroom. If this is possible, we must offer this. And if this is not possible, it could be a hotel which is close by, or it could be something like Dome if there's a financial problem.
Great. Question for Dr. Mashru and Dipali. At what point would you feel that a particular patient you've been home treating as family physicians really needs to be shifted to hospital? And how can you assure that you get a bed at that juncture? You're muted, Dr. Mashru. Yeah.
Yes. Red flags are the abnormal blood parameters, then cough, breathlessness increasing, high-grade fever, or second week we get fever again, second spike, then post-hoc saturation below drops by 3%. We admit the patient.
Yeah, great, good answer. Question for Dr. Sangani. Roshni, what is the mechanism by which diabetics are so exquisitely prone to COVID? And does it apply even to a very well-controlled diabetic? Someone is asking, someone with an HbA1c which is completely normal, would he also be at risk for worse outcomes? You're muted. All of you unmute, please. Yeah. Okay.
Sorry. So the data is showing that even well-controlled diabetes is having an increased risk compared to someone who does not have diabetes. And what's the underlying mechanism? We're still not, it's not clear-cut, but it's probably got something to do with insulin resistance. I don't think we've figured that out yet, how exactly it's correlating.
Great. Dr. Vaya asks a very pertinent question. Roshni, maybe you can take this. What is the incidence of panic, anxiety, the emotional, you're the holistic one, the other emotional aspects, the fear which COVID seems to be disproportionately breeding in our minds?
And Amita mentioned...
How do you deal with it as well?
Yeah, and Amita mentioned it, and I was glad, that in the home treatment of the patient, the emotional support is very important, because it's not just about rushing to the allopathic world and asking for the vaccines and the drugs. It's also about taking care of your entire sense of well-being. So managing sleep, managing that emotional sense of fear. So there are actually, it's okay, I think, in an allopathic world to talk about helping our patients do some sort of guided meditation on fear. That while we don't have a cure, how do we not create another stress response and an endocrine response from visualizing all these negative images in our head? Because in just tracking the news, you can start panicking. Even before the diagnosis comes, reading the COVID numbers every day, it's a fear-generating exercise. So you have to be careful with what you're putting in your mind and managing the sleep. But I have to leave this answer is for the frontliners. I think you guys know best how you've been managing the panic.
Great. We have people from Cape Town, from America, from Boston, in fact, who are sending us questions. This one is from a Dr. Sachin in Boston, who says, Amita, this is to you because he specifically asked, Dr. Nene, you said you aren't sure about drugs like HCQS and ivermectin. You are being polite. The science on them is very clear. They do not work. What would you comment to that?
Okay, so the thing is to each its own. So I'm very happily and I'm with pride, I'm accepting that according to me, HCQ works. I am an HCQ believer. This is my experience. I've treated more than 2,000 patients. Whether they got better on their own or with HCQ, I don't know, but it couldn't just be, and it just couldn't be something that only this patient got better and the other didn't. Similarly about ivermectin doxy, I actually believe in giving ivermectin doxy to those people who are exposed. And I actually have found that either those people are not getting any symptoms, or if they're getting symptoms, they are getting much fewer symptoms than another person in the family who's got infected. And these people may be actually elderly with comorbidities, but they're getting much fewer symptoms. So I basically feel to each its own. So Dr. Sachin, in India, we have the liberty to practice much more than we want to, with a lot of freedom, unlike Boston, US. So I'm actually talking about my experience, and I'm quite happy to, in fact, even accept in this huge forum that I believe in ivermectin doxy.
Yeah, Amita, but there must be a disclaimer there that none of that is backed by the evidence of any RCT.
Actually, I very clearly said this in my talk that everybody is they can use it if they want to. Since the question was asked, I wanted to be honest.
So if it took a huge trial like Solidarity to say that a drug like remdesivir doesn't work, I think we should be, as far as possible, guided by it. Let's move on. There's a Dr. Harish Shah who asked, should we start steroids immediately in a patient who tests COVID positive? I think I'll take that. And I've said, no, it's not the right time. You start a little later. And that too, if you have indications like hypoxia. Lots and lots of questions on favipiravir. Dr. Kishore Madhwani asks which vaccine should be taken. I don't think we have time for that. That's another subject altogether. Dr. Shah asks for Dr. Sangani, are obese patients more infectious than non-obese ones? Now, that is an interesting question. And he goes on to say, any answers on that, Roshni?
I've not seen any data on that, no.
He says in the context of viral shedding, and this is how we learn from our audiences as well, in the context of viral shedding in influenza A, these patients shed 40% virus longer than lean patients. So interesting that obese patients can shed more.
Possible.
Ravi, question for you, Dr. Pandey, who says, tell us about the physiology and rationale for awake proning. Is this something you would encourage all your patients while they're on oxygen? Ravi? I don't see him on. Ravi, can you hear us? No. We'll come back to him. Just ask him to join on by phoning in, please, one of the organizers. Someone asks about the role of yoga. It's complementary, I would guess, and breathing exercises are good. Indications for tocilizumab, I can try and answer that. It should be used sparingly. It should be used in patients who you're convinced have a cytokine storm, and that's a difficult entity to diagnose. Indications of plasma therapy I can take. Again, no large study has shown that plasma therapy is effective, though we do use it. If you are using it, use it early in the first 5 to 7 days and get a donor who has a high antibody titer. There's no point giving it from a donor whose antibody titer is near normal. Lady patient from Jaipur, this is a question from Dr. Gupta. Lady patient of 62 years old with mild COVID for 5 days. Past history of DVT, would you use an anticoagulant? Maybe Dr. Dipali and Atul as family practitioners would answer that. Would you give an anticoagulant in a 62-year-old with a mild COVID, but who has a history of DVTs in the past?
We should give it, I think.
Sure, I would agree with that again. A question, practical question for Amita. Should an old person move out of the house to another room, Amita, if out of the house if there's only limited space? Because that's another option, isn't it, to have them turfed out to family members while the patient is quarantined on his own at home. What would you say to that?
Suggestion. So the thing is that patient could be in the house for comfort and other people could actually move out. But the problem over here is that these people could be already exposed. And what we need to really understand is that normally people are infectious even without they having symptoms. And very often the people who are going to move out could be infectious and they could be asymptomatic carriers. So if they move out, it should not be in a relative's house. It could be in a hotel or something like that because they could be potential source of infection.
Sure. Another question to you: what do you mean by comprehensive home isolation? And I think that's what you elaborated, isn't it? Is there anything particular to comprehensive quarantine and isolation?
So I would just like to sum it up by saying the patient should be stable, should be like asymptomatic or mild symptomatic, and there should be a sensible caregiver rather, and it should be a single room for the patient along with an attached bathroom, and they should be in a condition to keep in touch with the medical doctor. Then it should be quite okay to treat these patients at home.
Great. Is Ravi on or he's disconnected? I don't see him. Another question for Amita. After 14 days of home quarantine and no symptoms of COVID, is it essential to reconfirm a PCR test? I think you've alluded to this, but maybe you could spell it out.
Yes, so actually the thing is that if the patient has mild symptoms who is being treated at home, no PCR is required, 14 days of isolation and the patient is cured. Please don't do RT-PCR, it may just pick up a dead virus and there'll be stress all over everywhere.
Sure. So we don't recommend it even after discharge from hospital that you repeat a PCR. A question for Dr. Sangani, and He says, what is the role of malnutrition? We've talked so much about obesity, but shouldn't malnutrition be an even more important factor in an impoverished country like ours? Yet we don't hear any news on the effect of malnutrition on COVID.
Yeah, actually, we need some data from India on this, and I wonder what anecdotal observations the frontline has. But being undernourished comes with its own increased cardiovascular risk. So I would expect that the same lack of protein and the lack of healthy fats from an intravascular inflammatory standpoint would be a negative. Yet we haven't seen any literature to say being underweight is causing the same effect. So I'm looking at what you, as the observers on the front line, have seen anecdotally.
I think we're seeing more obese patients than hypoxic, but that might not be the same in an impoverished village in Uttar Pradesh, where people are malnourished. So we need more data. Ravi, where did you disappear to? A coffee break?
I think the net gave it, Zari. The discussion was very heavy and enlightening.
Ravi, interesting question for you. Someone asked, can you tell us about the rationale for awake proning? Is there evidence for it? And are all your patients, when you recommend oxygen, presumably also awake? Also prone at home?
Right. So the awake proning comes from very weak data before the COVID pandemic. One or two papers in critical care, and by and large, it was looked at as an extrapolation of the ventilator prone concept. Ventilator prone took around 5-7 years to get validated. Awake prone comes after that. We ourselves have talked about it 2014 in abstract in the critical care proning in the critical care literature, and it quickly picked up from China and Italy and became standard based on the VQ mismatch theory. If it works on the ventilator, why not off the ventilator? And it has been tested both in awake, without oxygen, with HFNC, NIV, and so on. There's a recent paper saying that it will impact on mortality, but not many things are going to impact on mortality. So the VQ mismatch, redistribution, dorsal, anterior-posterior, and the perfusion ratios is one simple way of understanding why it works.
Ravi, another question from Lucknow for you. Giving a patient oxygen at home, may it not lull everyone into a false sense of security? And then when the crash occurs, everyone is even less prepared.
Absolutely. So I think we start with A, Amita, who outlined who goes into home isolation, B, Zari, who reinforces and puts so many checks and balances, and C, the fact that we are saying that though Western guys are saying put it in as a proactive program, in India it's happening as a I cannot get a bed or I don't want to go into a hospital program. In such a situation, you already have that situation. Once you get a bed, you're going to go into that particular setting. And yes, until you have careful monitoring, you can have that risk, but that is the key to the success of the whole thing.
A question from Varda, which I want Dr. Dipali to answer. She's been quiet so far. If a patient who you were treating at home insisted on a home visit, that's a difficult one. Would you go, a COVID positive patient? Any precautions you take? And how often have you needed to actually do this? Or would you say, sorry, I'm not coming?
Yeah, so during all these patients who were home quarantined with us, none of them actually ever insisted on a home visit from us. We were doing the virtual rounds, and whenever they would have a new complaint, again, those were the extra calls that we did. So most of them, as we had mentioned, they were having mild disease, and those who had a fall in O2 were advised to get hospitalized. So we actually never got to do it. But at the back of our minds, we did have some preparation that if there would be a need, then we were going to go with all the PPs and N95s and everything, and were ready to do that. But it never happened.
Great. Nice question from Dr. Rati Godrej, who asks, should you do HRCTs up front on all patients with COVID? Maybe I can answer that. My answer would be no. If I had COVID, I wouldn't want to do a CT unless I was really breathless. CT shows you so much more. It can cause worry and confusion. So I don't think a CT is essential on every patient. There must be clear indications. Lots of questions on post-COVID fibrosis. I'm afraid that is a whole different topic, and other webinars exist for that. Someone who asked from Chennai, what is your take on initial reports from Solidarity mentioning no agent has survival benefit for patients? Well, let me see who the doctor is. Dr. Sravaran. What can I say? It was disappointing, as Ravi says, but I think a good doctor is an open-minded doctor who listens to evidence. So this was the drug that we were all using in our ICUs, or at least on all hypoxic patients with COVID. And we wait for more data. Since I'm part of the trial, I can say that because the data was so striking, the WHO plans to continue with the remdesivir arm. in ongoing data analysis. But now they're adding the more interesting drugs, the monoclonal antibodies, the kind that Donald Trump received a cocktail of. And this is the beauty of a so-called adaptive trial. What else? Someone says, topic so well covered, I have no more queries. How's that? And maybe that is... No, we have a few minutes more. I thought that would be a nice note to end on. Role of Ayurveda, role of yoga, we've covered. Ravi, maybe this one for you. Patient with COVID has a WBC count which is 16,560. Dr. Asma, she's very specific. Plus his CRP level is 9, his LDH is 366. What could be going on?
Okay, so it's a very...
WBC count, Ravi.
Sorry, say that again.
A patient with COVID who has a high WBC count of 16,000 plus.
Yeah, so it's not typical in COVID to get a high WBC count. Though we would think of a stress response, you should first find out whether they've been given a little steroid like a Mickey Finn, as Zarir would remember from his UK days, because steroids are very ubiquitously given and that may have elevated the count. Otherwise, one would certainly launch a diligent search for some secondary infection along with the COVID, and the strategies for steroids have to be looked at very carefully when you are thinking of adding them onto your treatment paradigm for such a patient.
Great. A nice question from Dr. Anil Kumar Mittal from Kanpur. I've seen some COVID patients recover, but continuing with a low-grade fever for more than 4 weeks. I could not find anything wrong when I tested them, despite all possible investigations. Is this COVID still continuing? Perhaps I can take that. This is almost certainly, if all his other parameters are normal, part of the post-COVID syndrome or long COVID syndrome. COVID leaves a tail which continues to wag for some time. And often when the patient says he's got fever, if you ask him to check in the axilla, it's not matching. It's a feverish feeling, which is the evening rise in temperature all of us get physiologically, but there is no actual documentation of temperature. Just knowing that often reassures many of my patients. There's a question again from Boston. Dr. Ravi, home care was already a standard in New York City in April. In fact, Dr. Udvadia wrote about it in the Indian Express many months ago. There's a gap between fast-moving evidence and its availability in India. What ails the medical fraternity in India? I think that's a justified criticism. You said as well, we haven't learned from city to city, let alone from country to country. What would you say, Ravi? How would you counter that?
It's more like a comment than a question. I would think that he's trying to bring out the inadequacies which we all went through. But this time we have this comparison inadequacy when we see that no country in the world has actually done what it's supposed to do, including the country from the questioner. You realize that it's ultimately introspection and the fact that pull out all the strategies from the closet. If the repurposed drugs were looked at so carefully, why aren't we looking at other strategies which make more sense for streamlining care so as to make both morbidity, mortality, and patients' lives better?
Great idea. Atul, a question for you. What about the stigma in your minds of patients to even agree to do a COVID test and a PCR swab? Some just don't want to know because they fear their building may be closed down or whatever it is.
How do you convince them? Yes, it is very common. They get scared. I said, don't get scared of municipality. Get scared of corona. Municipality will come and do free of charge your sanitization. And this is not like HIV that you have stigma. Everybody is getting corona.
Okay, let's ask Amita these next two questions. What is the role of inhaled steroids in COVID? And let's finish that one first, Amita, and then there's another treatment question which you'll answer.
Okay, so basically the patients who are having a lot of cough, I have found inhaled steroids to be beneficial. And there are a number of studies also which have come in that inhaled steroids do help. So I believe in giving inhaled steroids. I kind of feel that they are quite safe. And I make sure to gargle their mouth and throat after that.
Dr. Ram Ragani, my friend who's a general practitioner in Ulhasnagar, asks, can we start Favipiravir in a suspected case of COVID-19 whose RT-PCR is negative? Now, American purists would raise their eyebrows at that one, but tell me, Amita, what's your take on that?
So
RT-PCR negative? But
if the patient has exposure to a COVID positive patient, for example, if somebody in the house is COVID positive and this person has all the symptoms, then there's no, and even with a negative RT-PCR, there's no reason to believe it could be something else. So we could give, because we know RT-PCR sensitivity is 70%. If you want to be really a pure person, then you can keep on repeating RT-PCR, but you could definitely start Favipiravir empirically.
I would tend to agree. If 3 people in the family are down with proven COVID and the fourth one gets fever and the sniffles, you would consider the same drug. Now, this is everyone is getting bullets from the audience, which is nice, really. This is one directed at me from Dr. Santanu Saha from Calcutta. And the Bengalis always ask the most difficult questions. He says, Dr. Udvadia, is favipiravir of any substantial use in COVID? Does any RCT support it? So that's a good question. There is limited evidence, let's all be honest, even though this is a symposium supported by one of the manufacturers of this drug. But there is a reasonable amount of data. And as I said, we have just completed the study of 150 patients. I can't reveal the results because it is under peer review just now. All I can say is there's a whole lot more data for drugs like favipiravir than there is for some other drugs. It is antiviral. It does work in influenza. It has worked in Ebola in the past. I think we need to wait for more data, but you're right, absolutely right, that we don't have enough at present. It just now seems to be about all that we have, and that's why it's embraced by most doctors. A couple of maybe the general practitioners here can answer this. Dipali, this one is for you. A couple of COVID patients have excessive sweating at night in COVID. Any specific reason for that?
Yeah, we did hear a lot of patients complaining of night sweats, but probably because they were taking the paracetamols round the clock, whether fever or not, because of body ache. So we attributed it to the paracetamol, and also sometimes they would not be having enough water, dehydrated. Many of them were not switching on their air conditioners and have those sweats because of that. So these are the reasons that we actually found. Some of them were also complaining of hiccups. That was one of the common complaints, and there was no particular reason. Maybe all the medicines that they were taking or the gastritis caused by that. Not sure about it, but yeah, night sweats and sweating was one of
this intriguing symptom from Italy of loss of taste and smell, which we've all heard so much about, but doesn't seem very common in our patients. Okay, I think Dr. Enid from Margao, Goa says, very good webinar, and so does my friend Dr. Satish from Bangalore. So that's a good note for me. It's exactly 8:30. Let me hand it back to our organizers, and maybe they want to sort of make some concluding remarks. But I would like to thank all my panelists. When they told me we had 2.5 hours, I thought, oh no, what are we in for? But I think you will all agree that it has really flown. Time has really flown. So thank you. There are so many more questions I haven't had time to answer. Maybe they can be sent on to each appropriate speaker by the organizers, and we can try and answer. Right, Dr. Dushyant? So it's back with you, Dushyant.
Yes, sir. Am I audible?
Yeah.
Okay. Thank you, everyone. Thank you, Dr. Udvadia. Thank you, Dr. Nene, Dr. Sangani, and Dr. Mehta and Dr. Bhatt for giving us those insights and such a nice deliberation from all of you. And it was a very wonderful program for us. And I hope that everybody out there has learned a lot. And the quantum of questions that has been asked by the live audiences is a measure of the program that we have just concluded. So I would thank each one of you for sparing time out of your hectic schedule and being the part of this webinar and giving those wonderful insights and takeaways to each and every audience out there. So thanks everyone. And I would also like to thank our live audiences who have spared time out of their hectic schedule on Sunday evening. This is another achievement for us, that on Sunday evening we could able to reach out to more than 2,000 live audiences right now. So thanks everyone for joining us, and I hope the learnings that you had with this particular webinar would be useful in managing patients at home. And I would also like to thank our commercial colleagues for giving us this opportunity to do this webinar on home care management of mild COVID-19. And last, I would like to thank our digital partner DocMode for giving us this platform where we could able to do this in a very seamless and smooth manner. So thank you all, and I would end or conclude this webinar with a pertinent message to all out there that namaskar, stay safe and stay healthy and do well.
Thank you.
Thank you.
Thank you so much.
Thank you.
Goodbye, everyone. Thank you.
Bye. Thank you. Thanks.